everyone. Good morning. Welcome, welcome. Thank you so much for your patience. We did have a little bit of difficulty, but now you get to see images, and we want it to be visual as well. Thank you so much for being here, for taking the time to spend your beautiful Saturday morning with us. We have a wonderful time for everyone here, especially it's a learning time, and it's a opportunity for all of us to learn about Duchenne's and living with Duchenne's, and what does that really mean. My name is Sima Perez, and hey, I see a lot of familiar faces. It's so good to see you guys. What you see behind me, that is Christopher, my son, my husband Bernie, Rebecca, my daughter. Christopher was diagnosed at the age of 2 with having Duchenne's muscular dystrophy, and our life changed. It has not been the same. However, Duchenne does not determine what we do and who we are. As you see, we take my son everywhere, and he currently uses a power wheelchair. And that was last year at the Cure Duchenne conference, yes, in Orlando. So we want to give him the best life we possibly can. Yes, there are a lot of milestones that are not easy, but we face them with dignity, with strength, and knowing that we are here to support our boys. Christopher is now 19, and I was just telling one of our moms that I was freaking out last year when he turned 18, because when Christopher was diagnosed at the age of 2, the doctor said, that was 16 years ago, Christopher will only live to be 18. So as a mom, that 18th birthday was just leading up to it. I was a wreck. But he's here, he's thriving, and today we're going to, thank you. Today we're going to learn about how to live well with Duchenne's. And so without further ado, let's get started. I would like to welcome our host and sponsors. Let me begin by bringing our mighty Karen Gilmeno, Executive Director of Hunter's Heart Foundation.
Good morning, everyone, and thank you for coming. And for the sake of time, I wrote my speech out, but I'm not going to read it for the sake of time. I did everything that Sima says. Sima was the mom that I called when Hunter was diagnosed at 4 years old. At 2 o'clock in the morning, when I left the hospital with Dr. Ramos Platt, anytime he was coughing and I didn't understand it, I reach out to Sima. So it's really important to have someone that you can call on when you don't know what to do. But I just want to thank you for coming and being a part of Hunter's Heart Foundation. And we really, really want to support the community. We really want to advocate, provide community resources for them and community outings, because their circles get smaller and smaller as they get older and older. And so the boys, they look forward to coming together and meeting at the conferences, and we go to the movies and wheelchair, paddleboard. Adaptive paddleboard, so they can get on the water and do things that other kids can do. So thank you for coming, and I'd like to invite our generous sponsor, Mitch. He is the CEO of Kaiser. Please give him a hand as he comes up.
This is for you. What is this?
It's a mic.
This is a mic? I don't think I need it.
Recording.
Seema, your son's a cool young man. Because I was out there talking to him. He's just a really cool guy. They're having a lot.
That's Turbo.
Turbo.
That's her
Oh, okay. He's a cool guy.
They don't look alike. But he's cool too. Christopher's super cool.
They are. They're just a lot of fun out there.
That's That's Turbo.
Welcome. My name is Mitch Winnick. I'm the CEO and the Senior Vice President of not just the Downey Medical Center, but all of our service areas. So welcome to the Watts Medical Office Building, and thank you to the LA South Chamber of Commerce and the Hunter's Heart Foundation. Together, hosting this it's really a privilege. Just a little fun fact history. We've actually been in this community for over 50 years. Over 50 years serving in the Watts community. And this building, beautiful building, right? Yeah. Gorgeous building. We built it, actually last month was a year anniversary for us. It was kind of bittersweet for us, frankly. I don't know if you know anything about this community, but this building happened because of a gentleman named by the name of Bill Cosby. I don't know if anybody here knows or heard Bill Cosby. He was a pioneer who's been a part of this community for 60, 70 years before the civil unrest. I mean, it was a long, long time ago. And he helped start the Watts Learning and Counseling Center, which provides education and counseling for folks that have money or don't have money. And so because of him, we were able to build this. Oh, you need this? You need it? I got to put this on. They're telling me. Okay. All right. Is that better? Okay. Because of him, we were able to build this. He passed away last month at our year anniversary. But in a way, when they asked me to come say a few words, it was a privilege because this embraces his legacy. All he wanted us to do, all he wanted to do was have community leaders work together to help educate and serve the residents of the community to ensure we had equity and health and access to all. So this is a perfect time to do this. This community center was never built. The one you're sitting in right now was never built for Kaiser. It was built to share within the community. And so seeing the chamber and the foundation and us work together to do just that, it really is a privilege. And Duchenne's muscular dystrophy couldn't be a better one to do it on. And we've got a ton of great experts. One of them is our own, I was going to say. David Mackian, one of our leaders and physical therapist, is going to be doing some education here. And so we're really proud of that. And I am going to ask my buddy, because I've joined the South LA Chamber of Commerce as a board member too recently. And so Dexter, our president, the president of the chamber, is going to come up here and get us going. Thank you guys for being here. Have a great experience. Enjoy, learn. It's going to be a lot of fun.
I need that mic.
Oh, you need that mic? Okay. Let me get that.
It's going to be on me, man. I already know. Okay, I'm just going to hold it like this. All right, good morning. Good morning, everyone. Thank you all for coming out. Thank you, Mitch. Thank you, Ryan, for hosting us today at Kaiser Watts Learning Center. Isn't this a beautiful facility? Yes. I haven't been here since pre-COVID. The last time I was here was like 2019. And Damon, I think you was here with us then too. But we used to have our monthly meetings here. We had community roundtables here, not in this building. It was a little room over there in the front. But wow, I came in this morning, and I'm like, wow. And it's parking too. Man, where do you find that much parking in the city like that? Underground covered parking. Isn't that beautiful? So thank you again, Ryan, Mitch, and the whole Kaiser staff for hosting us. Karen, God bless you. And Hunter's Heart, Hunter's over there. But Hunter's Heart Foundation, Karen's been with us for almost a year now in LA South Chamber of Commerce and the LA South Hope Foundation. And she came in and shared her story, Hunter's story. And, you know, my heart melted. And of course, it's like, oh, how can we get involved? And so she invited us to participate in different events. The first one was the 5K walk, which we're going to be doing again this September. And then she mentioned, I said, what else you got? What else you got? She said, I want to do it. I do a conference once a year. I said, okay, well, we're in. However we can support, let's support it. Oh, and the toy drive, yes. Yes, so ladies and gentlemen, so thank you, Karen and Hunter Heart Foundation for the invitation on us to participate. I want to thank all of our members, our partners, our board members that's here today. Y'all can just wave your hands, all of our members and partners. And Damon, wave your hand. Damon back there. Damon, I told Damon did our video almost 10 years ago, our promo video. And we're still using it, David, so we need an upgrade. We need a revision on that promo video, but it still works. It's still beautiful. But LA South Chamber is not your average chamber. As you see, we do a lot of community engagement. We found this organization. I grew up 5 minutes right around the corner here. That's where I grew up at. And I can tell you all the stories, the good, the bad, the ugly, of being in the community. But more importantly, like I said, continue to give back to the community that we serve. This is personal for me because this is my community, and like I said, just to see it flourishing now and then bringing programming and events here. So our chamber, like I said, we do a lot of community engagement. We have a foundation, which we're celebrating our 5th year anniversary for our LA South Hope Foundation, and that was created to engage the community, work with a lot of nonprofit organizations, faith-based organizations, and community-based organizations, so we can, collaborate and bring resources to our community. So again, I could stand up here for another 15 minutes, but I know Karen is going to start throwing stuff at me and sit down. But I just want to say welcome all of you all. Thank you for your support. Our prayers are with all of you all. It is Easter weekend. And, what a better time this time of the year, a time of hope. And as you see, we're about hope, helping other people every day. So God bless y'all. Have a great day today. And thank y'all for coming out.
Thank you so much. Thank you, Dexter. And now, as a matter of fact, we're back on schedule, everyone. This is great. I am very honored to introduce the next set of panelists. I call them the Dream Team because Children's Hospital of Los Angeles is bringing hope, but also they are caring for our children. And I am so proud to introduce Dr. Ahmed Abu Hamad, medical doctor at CHLA, Dr. Lee Ramos-Platt, neurologist, leads the MDA clinic at Children's Hospital of Los Angeles, and Cheryl Barton, cardiologist, is also part of the MDA clinic at CHLA. They are the multidisciplinary team of professional doctors from Children's Hospital. And so we're going to remove those pictures and put their information up there because they have a lot of wonderful information for all of us when it comes to the multidisciplinary care for the patients and families living with Duchenne. All right, let's start. There you go. Let's give them a big round of applause. Yes, ma'am.
Hopefully this, PowerPoint? Oh, I can just manage it from here. Okay. You do everything. Okay, perfect. Yeah, that's the right one. And this is the clicker? It is. To record? Oh, thank you. Good morning, everyone, and thank you for having us here. Thank you, Karen, for inviting us and for the introduction, Seema, for doing that. I'm Lee Ramos-Platt. I'm one of the neurologists at I'm Lee Ramos-Platt. I'm one of the neurologists at Children's Hospital Los Angeles, and I do direct the Duchenne clinic over at Children's. Today we are going to talk about, we'll set the groundwork for an overview of gene therapy and Givinostat in Duchenne muscular dystrophy. Let me see if this works here. Oh, I'm going to try to move it from the. Did it work? Let's see. Oh. Okay, before I go, I have to say all of my disclosures. So these are my disclosures. I am a principal investigator for multiple industry sites, and I've spoken for industry at sponsored events. I'm also on advisory committee, but I usually will donate whatever honorary they give me to either our program or other charities. So I try not to keep all of that, even though it's on the Sunshine Act. I do want to introduce our team. So we have neurologists, we have cardiologists, we have pulmonologists. Right now, it started off with just one of us. It was just me for a long time. And Cheryl's colleague, Dr. Mentier, and then one pulmonologist. And we started back in 2010, and we've grown since then. We now have 2 child neurologists who are fellowship, trained, and boarded in neuromuscular medicine. So that's Dr. Tiongson and Dr. O'Rourke. We have a nurse practitioner, and so if you are on Givinostat, you are seeing my nurse practitioner quite a bit. Her name is Lauren. And then I did want to introduce you to our speaker for the first half of this, and that's Dr. Ahmed Abu Hamad. He is our child neurology resident, and I'm hoping that we can keep him to be our third neuromuscular trained physician. So I will have him start, and he does want to pursue neuromuscular and care for Duchenne in the future.
Yeah. Thank you for having me here. It's an honor to be here. The first part of our speaking will be about the overview about Duchenne muscular dystrophy. I believe most of you know about this information, but as a revision for that, and we'll give you a little bit update about the last update about the guideline of Duchenne muscular dystrophy, and the second half will be with the Dr. Ramosablat about the gene therapy. So what the Duchenne muscular dystrophy, I think most of you know about. It's X-linked recessive neuromuscular disorder that affecting the gene that called DMD gene, a dystrophin gene, that affected the ability to produce protein that's responsible to the functionality of our muscle. It's the same name, dystrophin. So when that gene affected in the patient with Duchenne muscular dystrophy, that's ability to producing to maintain the muscle healthy, it will be less. And the Duchenne muscular dystrophy is happening, it's mainly because X-linked recessive, it's mainly in the males where the ratio reaches up to the incidence between 1 in 3,500 to 1 in 5,000 of the male birth. And also because this Duchenne muscular dystrophy, it's mainly progressive muscular disorder that's happening to starting with the early symptoms of the muscles weakness, usually started at age 3 to 5 years old. However, that will be progressive, so the diagnosis will usually be happening at age 4 to 5 years old. This is fine. So because it's all of that about the Duchenne muscular dystrophy, it's about the dystrophin. Why the dystrophin? The dystrophin is very important protein because it's part of the cytoskeletal protein that is essential for the strength and the stability and the function of the muscles fiber. And without that, that's affecting to the stability of the muscles fiber. So it's also playing an important role in the mechanical reinforcement of that, what we call the glycoprotein associated complex. And without that, that make it that vulnerable to the proteolytic enzyme that can be degradation of these muscles fiber. So without the dystrophin, you're losing the muscles, the breakdowning of the muscles, and eventually losing of the motor function. Next. So this is the picture about this dystrophin here. That's important of the dystrophin and how that's functionality of the dystrophin about making the stability of the muscles fiber. And without that, all of the structure will be damaged. Next slide. Next. So what the signs, you have early signs of Duchenne muscular dystrophy that's happening. Most of the time that's affecting initially with the ability to walk, to run, and to jump as a kids. However, sometimes seeing ability to doing sometimes that pseudo hypertrophy in the calf muscle, it's enlargement of the muscle, but it's pseudo, it's not real. It's merely replacement of the muscle cells with the fat tissue that can with the early sign of the motor symptoms, and also abnormal gaits, which is called waddling gaits. Sometimes it's calling with Gower sign when you're seeing the kids to being from the complete sitting position to standing, have many steps to get that. So is that when looking at that, this will be, it's one of the early signs we can detect. Even it's merely motor functional affected also can be presented initially with non-motor. It's not the typical, but can be presented with behavioral issue and ability to the poor weight gain, sometimes affected also the behavioral issue or learning difficulties. Next. So the main thing about the Duchenne muscular dystrophy is the weakness. Usually the weakness, it's merely starting with the proximal muscle before the distal muscle, starting with the lower extremity before the upper extremities. And we mentioned about the waddling gait, about the pseudo hypertrophy, but usually without the treatment, eventually loss of the ambulation between age 10 to 12 years old. Next. Yeah, this is what we seeing about the pseudo hypertrophy. You're seeing the muscle, it looks like bigger, but it's actually weaker because it's not real muscle, it's merely fat tissue. Next. Yeah, I was we speaking about the Gaussian when asking the kids to from the sitting position to starting to the standing, they're taking many steps before to able to have the fully standing positions. This is called Gaussian, and leading to give us a clue about the proximal muscles weakness. Next. So one of the things we need to focus, it's Duchenne muscular dystrophy, it's not just motor or neuromuscular disorder that can involving multi-system involvement, can involving the cardiovascular, can involving the respiratory system, even also the other system like the GI, the CNS, and also to the endocrine. And as we mentioned, it's a progressive muscular disorder that's starting initially affecting to the endurance, is unable to walk for long distance, then this eventually lead to the loss of the ambulation, and eventually the most serious complication lie the respiratory dysfunction or cardiomyopathy eventually. But with that, the progression of the disease and the course of disease can be changing variant from the individual to individual. It's not all of the Duchenne muscular following the same course and the same severity. Next. So all of that regarding to the dystrophin, we can classify them. It's like muscular dystrophy disorder or dystrophinopathy. It's depending on the how functionality of the dystrophin we have. If there is, we don't have a dystrophin at all or very low percentage like 0 to 5%, we're going to the severe form, it's called Duchenne muscular dystrophy. However, when we have more functionality of the dystrophin 5 to 50%, it's called milder form of dystrophinopathy like Becker muscular dystrophy. And the difference between them, it's mainly about the course of the disease, and the onset of the symptoms is different. It's usually later onset and less severe form, and the courses can be different a little bit. And there is a category between both of them. It's also depending on the percentage of the dystrophin we had, can be considered its severe form of Becker muscular dystrophy or milder form of Duchenne muscular dystrophy. Next. Yeah, that's the same thing about the percentage of the dystrophy. Next. Yeah, going to the genetics, we mentioned it's X-linked recessive, so most likely or primarily affecting the male, but very rare can be affecting the females. And DMD or dystrophin gene, it's one of the largest gene in our human. Next. That can be involving variant, multiple mutation we will mention in the next slide. But generally, this is how the inheritance of the Duchenne muscular dystrophy is started with that mother carrier the mutation with also an affected father. With this possibility that having 25% have the possibility to having a son with have Duchenne muscular dystrophy, and another 25% having a daughter, we have the carrier of the mutation that can be transfer the mutation to the next generation. Next. Yeah, as we mentioned, it's one of the largest gene in the human body. So there is multiple mutation that can be happening. The mutation that affecting the exon, that mainly the deletion, up to 77% of all of the mutation in the Duchenne muscular dystrophy, it's deletion, and up to 70% on the Becker muscular dystrophy, it's exon deletions. So most of the mutation happening from the deletion part. There is also the duplication, the partial exon duplication that happening also up to 11 to 13% of the patient with Duchenne. The other variant, it's more rare form, but that still can happening. It's what's called SNV, or a single nucleotide variant, or splice site variant, or small insertion or deletion in the coding regions. Other than that, sometimes it's not following that X-linked inheritance. It's atypical for Duchenne muscular dystrophy, not following that. But if that's happening, it's most probably not the mutation in the dystrophin itself. It's we call when the mutation mainly in the dystrophin associated glycoprotein, but eventually producing the same effects by the degradation or breakdown of the muscles fibers. Next. Yeah, this is one of the example. Usually when Duchenne muscular dystrophy leading eventually is called out of frame deletion or out of frame duplication. All of that lead to what we call the premature stop codon. So this stop the reading from here, this point, so no functional protein will be produced at all. Also the same thing in that duplication, when we also hear duplication for exon 46 that lead to the premature stop codon. So that's the mRNA unable to read this frame, so we'll be producing nothing. No functional protein will be produced. On the other hand, when going to the Becker muscular dystrophy that causes in-frame deletion or exon, that's any frame that's affected for sure the ability to the reading to the frame, but it's still readable. So at least they will be producing partially functional dystrophin, so the symptoms will be milder and the onset will be late. Next. This slide is very important because it gives us the clue about how the developmental of our management or the therapy, the gene therapy, what's called single exon skipping therapy, with this eligible for about 30% of patients with Duchenne muscular dystrophy. For example, the typical presentation here with the mutation, deletion mutation for exon 45, and this ability to premature stop codon, so non-functional dystrophin will be produced. Here, what we will do with this therapy is going to what we call producing using AON, which we call antisense oligonucleotide, that's hiding of the exon 46 from here, so able to match the 44 with 47, so it's able to reading the frame, to continue reading the frame, so we'll be at least producing partially functional dystrophin. Okay, next. So this is the guidelines, the last updated guidelines regarding to the Duchenne muscular dystrophy that's happening in 2017. That's updated and mainly focusing about that improving the survival with multidisciplinary team. As we mentioned, it's multi-system involvement, so we need to involving the multidisciplinary team from the subspecialty to cover all of the regarding Duchenne muscular dystrophy, and also what's using as anticipatory care, so looking for the prevention and also early detection and interventional of modifiable complication. And the second thing, focusing on the quality, not also just longer life expectancy, also the quality of the life, important of the social cycle support and holistic approach to the management of the cases of Duchenne muscular dystrophy. Next. The diagnosis, one of the things that covering in the last update about to the evolving the diagnostic and the therapeutic part of the Duchenne muscular dystrophy. In general, we can go on the next slides. In general, we starting when looking for Duchenne muscular dystrophy, if there's strong family history of Duchenne muscular dystrophy, or there is earlier sign, we will spoke initially about the ability to the ambulation or the walking, or even there is no family history like presenting at Gower sign or toe walking. Starting with the first simple blood test that looking for the muscle enzymes like creatine kinase. If there is low, very unlikely to have Duchenne muscular dystrophy, so we done for that. If there is high in 1,000, there is possibility to Duchenne, so going to the genetic test. The genetic test, there is multiple genetic tests, but we are covering the deletion and the duplication that almost 70 to 80% of the patient with Duchenne muscular dystrophy, so we're going with what we call comprehensive genomic hybridization assay, or the MLPA PCR, that covering about the 70-80% of the cases. If that's negative, if positive, it confirm the diagnosis. If negative, we can go into the next generation of the DNA sequencing. And the genetic sequencing that covering all of the rare cases like the SNV or like the small deletion or insertion of the codon sequencing. If there is negative of genetic sequencing, we still have high suspicion we have Duchenne muscular dystrophy, we can go into the muscle biopsy. It's rarely to go too far to this point, but if there is still high suspicion and all the genetic tests negative, we go into the muscle biopsy next. And the muscle biopsy, we're looking for the presence or the absence of dystrophin. If the absence of dystrophin, this confirm the diagnosis with Duchenne. Okay, next. Yeah, that's it. Yeah, next. Last thing, I think the psychosocial management, I think it's part of that. Our colleague will cover this topic. But in general, we looking also for our patient with Duchenne muscular dystrophy and their family are vulnerable to having an anxiety, the depression with all of these things. So we need to look for these things every time they visit us in the clinic. Next. Last things about the steroid, the last update is still emphasize on the continue the treatment with the steroid, even with this after the losing of the ambulation, because the long-term benefit even with the steroid, preventing to the involving to the loss of the functionality in the upper extremity and the respiratory functionality, and also preventing the scoliosis surgery, and also delayed the loss of ambulation. And there is many studies now going on to the benefit of starting to the steroid even before the early physical decline started. And that's it. Yeah. Thank you so much.
Thank you, Dr. Abu Hamad. He still has another 3 years. He's not doing. He's doing pretty good. You know, he has 3 more years with us to keep on training with this. So I am glad. This is how long it takes to make a child neurologist that takes care of Duchenne. It's 4 years of medical school, 3 years of pediatrics, and he was a pediatrician before he decided to come back to neurology, and then another year of fellowship, and then just more years of experience. So it takes a long time to become one of us. I'm going to go to the next slide. So I'm glad that he had the hard part, because he had to lay down the whole foundation. He had to basically take down a publication that's like 30 pages long and talk about it in like 12 minutes. So I have the easier part. So we are in the era of the genetic therapies for Duchenne. And he already mentioned some of the antisense oligonucleotides, exon skipping, 3 that come from Sarepta, and 1 that comes from NS Pharma, which is currently FDA approved. When the guidelines were written in 2017, we just got the first approval for Sarepta's first medication, eteplirsen, and that was for 51 skip. So the guidelines have to still get more updated, because now we've gotten a lot more drugs since 2017, and definitely now since 2023, we've gotten gene transfer therapy. I'm not going to go over the exon skipping as much, because I think what the hot topic is right now is the gene transfer therapy. Next slide, please. So Dr. Abu Hamad already mentioned it. The gene for Duchenne is humongous. The way that we give gene transfer therapy is we do not give the entire gene. We can't get it into a person that way. What we actually do is we give a portion of it. So he also mentioned that there are some mutations that they make a somewhat functional dystrophin, although it's not perfect, and that's why you get Becker. So the idea behind the gene transfer therapy right now is to genetically transform someone from a Duchenne into a Becker. And the way we do that is we shrink down the dystrophin. We shrink down by taking the best parts of that dystrophin molecule, putting something called a promoter, and then some other decorations on it so the body takes it, and we put it inside a virus. And it sounds crazy, but we basically infect the kids with a virus, and then the virus infects the muscle cells and other cells with the new DNA, and then the new DNA makes a brand new protein. Sounds like something that, I don't know if you guys are, I don't know, maybe you guys would know Star Trek, but like, I don't know. Something that, you know, like Dr. McCoy would do, you know, way back when. Next slide, please. So what do we know about gene transfer therapy so far? And these are some of the controversies that are brought up as well. So the first thing is that the first study was done 8 years ago, I guess. I used to say 7, but I think it's 8 years ago now. And there were 4 boys. The 4 boys between the ages of 4 and 7, and all those boys are still doing really well. And I will show the publication from last year that shows that. The study for Elevidys, or delandistrogene moxeparvovec Rockel, did not hit primary endpoint. And we're going to talk about that. If it didn't hit primary endpoint, why in the world am I giving this drug to your sons, right? Because it did hit secondary endpoints, and we'll talk about that also. Patients still have muscular dystrophy afterwards. And that also is another point that I wanted to bring up, of why we treat kids that even after we've given them gene transfer therapy, we are still giving them steroids. Next slide, please. So this is the paper that shows the original 4 boys. And you can see here they are. All of them still, compared to the natural history, have done just far better. So these are the 4 boys, 8 years and out. They're still going strong. Now, these boys are exceptional. Sometimes we don't get this outcome. Sometimes we have boys that don't respond as well, and after a couple of years, they don't do this well. But so far, we've given quite a few doses at Children's Hospital. Most of our boys are doing pretty well. Next slide, please. So why didn't it hit primary endpoint? So primary endpoint was the North Star Ambulatory Assessment. If you've gone to the clinics, you know what this is. It's this battery of tests that they have to do. As Dr. Abu Hamad had mentioned, a good number of our patients have learning problems. They do have autism spectrum. They do have other learning difficulties. And to do this, and to do this sequence regularly, it takes a lot of concentration. Now, if you're a 4-year-old, we've done this before. We've had like this 10-meter walk, and in our old clinic space, there were these curved lines on the floor. I don't know who designed that, but they did not think about the 10-minute walk distance. When you have a 4-year-old doing that, they don't want to go straight. They want to go on the curved lines. Now, in our new clinic space, we have clouds on the sky. So when they're 4 years old and you tell them, can you walk straight? They're like, oh, but there's clouds. Oh, and there's an alien. And oh, there's an octopus there. So it doesn't work all that great. And so when you have to get their attention for this, they have the attention of a goldfish. They're not going to pay attention. And so that's why I think there's a problem with the North Star Ambulatory Assessment. Next slide, please. So what were the secondary endpoints? Time to rise. So this is something that from beginning of medical school, and I went to medical school in the 1990s. So from medical school, we learned that the time to rise it's something that we've done. It's classic. We know what those numbers look like. So the time to rise actually improved after gene transfer therapy. The 10-meter walk run time. Now, they may not be able to do the whole 6-minute walk distance, but sometimes we can trick the kids to doing a 10-meter because it's short. It's a matter of seconds, like 10 seconds rather than 6 minutes. And then the percent of dystrophin that was produced. This is the brand new Elevidys dystrophin inside their muscles. Next slide, please. So here's the study that actually shows that dystrophin actually improves after you give them gene transfer therapy. So here, 0, as Dr. Abu Hamad mentioned with Duchenne, and now after treatment, look, you're getting something showing up. So again, not perfect, but still a lot better. And we know that even small amounts of dystrophin, 1%, 3%, 5%, make a big difference in clinical outcome. Next slide, please. And because the kids still have muscular dystrophy, yes, we still give steroids. I also have started to give steroids to patients with Becker. And the reason why I'm doing that is because you still have muscular dystrophy. That process is still going on. It may be slower, but it's still happening. And so this is something that we've been now doing for the past couple of years. There's also a question I get about vamorolone. Should my kids get vamorolone? When we give gene transfer therapy, we give the kids a lot of steroids. And about a quarter of our patients ended up with fractures because of a lot of steroids that we were giving them. Vamorolone, we know, is that new medication. It's a new steroid instead of prednisone or deflazacort. And it does have a positive effect on patients with their bone density. We know that that's a distinguishing factor of vamorolone compared to the other two. But what we have found so far, and at first I heard about this at the PPMD conference, and then we started trying it on our patients. Vamorolone does not have the same effect as prednisone and deflazacort when it comes to immune response. And because we're making a new protein and a new gene, patients can still have an immune response to the gene therapy even months out. So when I switched my kids from prednisone back to vamorolone, I saw their CK go crazy high. And so that has already happened to us a few times, and so I'm not doing it again. I'm going to try to keep them on deflazacort or prednisone until I can learn more or find out how to mitigate this. And this was presented from 2 other physicians at PPMD also, that they saw the vamorolone made the CK go way up, and sometimes they weren't expecting it. Next question. Next slide. The other thing that came out in the clinical trials, I used to say in the clinical trials they were deaths, but it didn't pertain to Sarepta's product, which is Elevidys. We actually found out that there was 1 death that was attributed to the gene therapy that is now commercially available. It was a 16-year-old boy who was no longer walking, and he ended up passing away from liver failure. At Children's, we are kind of like a little bit nuts when it comes to monitoring and how much you are our best friend during the time of gene transfer therapy. But having said that, we know that we have seen deaths before in gene transfer therapy. We've seen it before, not just with Duchenne, but also with other conditions like spinal muscular atrophy. So far, ELEVIDYS is not that bad, even though a death is terrible. Deaths are terrible. But in this case, it was 1 out of 800. So that's a lot smaller of an incidence compared to what was seen in clinical trials with other compounds. But still, not something I want to talk to parents about. Next, although I have to. Next slide, please. Sarepta is also only approving certain sites to give it. They want to make sure that if we're the ones giving gene transfer therapy, that we are ready to take on any kind of side effect. So they choose certified, in general, certified gene transfer therapies. They're not just going to give it to anybody, just to give this medication. You have to have experience with gene transfer therapy. We have to have systems in place in case there's a side effect. Now for us, if you have a side effect, you guys have direct access to us. You have a cell phone, we have a gene therapy phone, a lot of you have my own personal cell phone number. And so basically what it is that you do not get a resident, sorry Dr. Abu Hamad, but you do not get a resident, you do not get a medical student, you actually get me, or you get Dr. Tiongson or Dr. O'Rourke. You get an attending neuromuscular doctor when you call that line. Next slide, please. So just to let you know, this is how it shows up. It shows up to our hospital, surrounded by armored guards, in this cooler that costs $1 million, literally, in order to transport this, and it has to be handled very carefully. That's why this just cannot be given to any, clinic. Next slide, please. And so in the end, even though there was that one death, even though we know it doesn't work perfect, and even though we know there's probably going to be a better generation of gene transfer therapy in the future, the reason why we are giving gene transfer now is because some kids don't have time to wait, and we all know the natural history of Duchenne. Next slide. So where we are in dosing, we actually started as soon as we could. So it got approved in June of 2023. We gave our first dose in August 2023. We thought we knew everybody, and then we had a surprise patient who we had to try to mobilize and give this to the patient within a month, which we were able to do. And I'm glad that he's doing well. There's a label expansion as of June 2024. We've infused 15 patients so far. We'll go for number 16 next week. Next slide, please. I'm sorry, I'm going to go a little bit over time. I'm going to talk about Givinostat really quickly. There was a paper that came out talking about the safety and efficacy of Givinostat with Duchenne muscular dystrophy, and it was actually quite favorable. But interestingly, this was a longer study. So most studies, they stop at about 12 months. If this trial stopped at 12 months, Givinostat would have failed. But because they actually extended it to 18 months, that's when we saw the difference with the boys that got placebo and the boys that did not. Next slide, please. So you wonder, how does Givinostat work? Well, there's things that happen in Duchenne, and that includes chronic inflammation. There's something with the adipogenic cells do not work as well. As Dr. Abu Hamad had mentioned, they start to lay down fatty fibrous tissue where muscles should be. And then there's also a dysfunction in the muscle stem cells. So that's what happens with Duchenne. Next slide. And so what that means is that we have chronic inflammation. So then because the body's in the state of chronic inflammation, the body does not make anti-inflammatory cells. The next thing that happens is the adipogenic cells are overacting. So they're going nuts, and they're just making lots of fat and fibrous tissue because they don't know when to stop. And then the next thing that happens is that usually the fibroadipogenic cells have some kind of support function for muscle stem cells. But when they're too busy dealing with this chronic inflammation and just laying down fat and fibrous tissue, they're not going to support the muscle stem cells. So the muscle stem cells also don't work as well. Next slide, please. And so that's what Givinostat works at. And I always tell parents there's two ways that can happen when you get injury to the muscle. You can either become fat and fibrous tissue, or you can stay as muscle. And so what the Givinostat does, which is known as an HDAC inhibitor, is that it decreases that overstimulation that is brought on by that chronic inflammation, and then it shifts the function of those cells from making fat and fibrous tissue back to making muscle. And that's why it seems to be working for our boys. Next slide, please. This is the dosing schedule. Now, so before, ITF Therapeutics wants us to go this way, to start at the highest dose and then go up the other way. And I brought this up to ITF that there's something about our population that for whatever reason, they seem to have more side effects. So I told them, I think from now on, I'm going to go this other way, low and then up. And they said, okay, you can do that. Because what I did not want is that if they had a bad reaction when we were using such a high dose, parents would just give up. Yeah, and that happens because their kids are already like pretty fragile. They don't want that to happen. So we're going to shift it the other way. Next slide, please. Okay, so when you're on Givinostat, so when you're on gene therapy, you're really my best friend. I'm seeing you every week for 16 weeks. When you are on Givinostat, you're Lauren, or my best friend, because we are seeing you every 2 weeks. Now, most other centers say that they don't need a visit. We need it because I'm a little controlling. And I really want to make sure that you are safe. We have heard of someone that died on Givinostat. We don't know all of the issues that were surrounding because the physician didn't even know that child started on Givinostat when the person got it. So that's the reason why I'm a little controlling, and I say, please, you are going to be my semi-best friend. You're seeing me every 2 weeks for the next 2 to 3 months because I don't want that to happen. Your boys are really important to us, and we do not want that to happen. We also check a cholesterol panel, liver panel, and platelets because these can become abnormal with Givinostat. Next slide, please. And then just quickly, the clinical trial landscape, Capricor, the HOPE-3 cells that are given every 3 months, they have a PDUFA date. So it's going to be in August, which is going to be wonderful. We are a trial site, and so I can't disclose how our boys are doing, but I see that one of the families is here, so she can disclose how her son is doing. Edgewise is also coming up down the pipeline. So hopefully they will have a PDUFA date soon. There are multiple gene transfer therapies that are being developed besides the one that we have. We are looking at better exon skipping, and USC is working on one of the places that's working on better muscle stem cell support. And so that's going to be exciting to see. They're in the earlier stages, but that looks actually really intriguing. Not to take the place of gene transfer therapies, but hopefully these things will add to the overall care of Duchenne. Next slide, please. And that's it. So thank you. So this is where I'm going next. These are my foster bunnies. So if anybody wants some really cool bunnies, those are foster bunnies. Thank you. Yeah. Okay. You want to introduce? I can introduce her. Okay. I'd like to introduce Cheryl Barton. So as we are growing a neurologist, the cardiologist had to keep up too. So Cheryl has been our newest addition for cardiology. She has been very helpful. She has been seeing our boys post-gene transfer. Every time we have an issue and we need them to be seen sooner, we call on Cheryl. So she is our cardiology nurse practitioner.
Wait, I get to use this. Okay.
So in full disclosure, I am not a cardiologist. I did not earn that title of a physician, but I am a nurse practitioner in cardiology. So I do, and I am have been a part of the MDA clinic for several years now. So I'm here to share with you what I've learned about the heart and Duchenne's. I have no disclosures, so when that slide comes up, we can go through that really quickly.
Okay.
Great, next slide. So along with the neurologic care and respiratory care, cardiology or cardiac care is one of the pillars in ensuring that there's an increasing lifespan, but not just that, but also the quality of life of our young people living with Duchenne's. The intention for today is to really just give a broad overview of the natural course of heart involvement with Duchenne's muscular dystrophy. We're going to review the medications, what they are, when we start them, why we're giving them, and then review, in addition to the medications, we'll also review what's really important is female carriers of Duchenne's and how the heart is affected by having the genetic mutation. And then most importantly, what families can do and what the kinds of things that your young people can participate in with respect to the heart. So super excited about that. Next slide, please. So the natural course of heart disease in Duchenne's is really well described, and it's generally divided into 3 stages. The first is a preclinical stage. The next is clinical stage, when we start to see more changes of the heart, and our young people start to develop more symptoms, and then end stage, where we do see a decrease in heart function. What's important to remember about it is that the progression of the heart changes doesn't necessarily correlate with the changes that are happening in the body. But they're both really directly related to having the lack of dystrophin in the cells. Next slide. So in infancy and early childhood, early elementary school age, that's a preclinical stage. And during this stage, the heart function and the structure are essentially normal. So and our young people don't have or don't exhibit any symptoms or don't complain of any symptoms. Next slide. When they reach later school age years and their early teen years, this is the start. This is when we start to see both structural changes as well as maybe the development of some mild symptoms. The structural changes is usually not perceptible to the eye, and we might not see changes in dysfunction in function at that time. But the changes are occurring at a cellular level, and one of the initial changes that we see is, although the function is normal, the heart size starts to measure smaller compared to their age-matched peers without Duchenne's. What that means is that the heart muscle is starting to be affected, and this is the point that we mark that this is the beginning of impending cardiomyopathy. Some of the symptoms that our young people it doesn't happen very often in the older elementary school age. I don't see it very much, but they will start complaining of maybe some palpitations. That's the most common that we see. Next slide. By their later teenage years and early young adulthood, it's when we start to see significant changes in the heart. But the interesting thing is that the function can really vary. Even at these later stages, sometimes the heart dysfunction can be very mildly just reduced. Sometimes it's moderate, and then in the more extreme cases, it can be pretty severe. We see very, very reduced heart function in very weak hearts. In the teenage years, they start to express more symptoms. The most common one is typically a fast heartbeat, but they can also perceive maybe some discomfort. They'll have things like swelling in their lower extremities. Sometimes they have a hard time breathing, especially in certain positions, or they take a longer recovery time when they are ill. Next slide. So you've seen the slide. It's not new. But just to go over it really quickly, like in the skeletal muscles, the dystrophin is also very, very important in cardiac muscle as well. The difference between skeletal muscle and cardiac muscle is that cardiac muscle is involuntary. It beats no matter what, and it beats all the time, every day, 24 hours a day. The dystrophin, the easiest way for me to describe it is that it's a stabilizing cell. So it stabilizes the internal structures in the cell membrane. And so for me, when I was trying to figure it out and make sense of it in my own head, it's like a shock absorber of a car. Now, I don't know anything about cars, but I do know about shock absorbers. And essentially what it does is it absorbs the impact of all the bumps on the road so that you preserve the integrity of the structure of your vehicle. But in the absence of that, the structure actually absorbs all of the force. And that's the same thing that happens in a heart muscle cell. Next slide. So in Duchenne's, that protein is absent. So next slide. So what happens in the absence of the dystrophin is that there isn't that structural mechanical support when the heart muscle is contracting. So over time, that causes a weakening of the cell membrane, and that causes tears and leaks. And the inside contents of the cell starts to leak to the outside, and when enough of that content leaks out, the cell muscle dies. The interesting thing is, though, is that it's not replaced with healthy muscle cells. It's replaced with scar tissue. And that scar tissue is just like the scar tissue on your skin. It's not flexible, it's not pliable, it's really stiff. And the more of your heart muscle wall that's replaced with that scar tissue, the weaker it becomes, the more it stretches out, and the weaker the overall heart chamber becomes. So typically, we'll see that in the lower left chamber of the heart on the outside wall. And we can start to see some of those changes depending on the therapies as early as their early teenage years. But by the time you reach adulthood or your later teenage years, it pretty much encompasses the entire left lower chamber. Next slide. So that's a lot of information to digest. But there's a lot you can do. And even though it's progressive, there is a lot of family and us as care providers can do and offer to our young people living with Duchenne's. It's really important because cardiac disease is the principal cause of complications and significant complications in mortality in our young people. But early cardiac involvement is a really key part of ensuring that not just the longevity, but the quality of life, because cardiac disease can be modified with medications. And the earlier you start the medications, the more impact it can create. There's also a psychosocial component to it as well. There was a study that was put out from the UK where they surveyed families with family members who had Duchenne's. And one of the things that they highlighted in that is that early cardiac involvement really made a difference for them because it gave them a deeper understanding of how the heart is involved in their the Duchenne's process, as well as it gave them a better understanding of the medications that were offered, so it led to increased adherence to the medication therapies. Next slide. Slide back. Thank you. So what's the anatomy of a cardiology visit? Well, a cardiology visit is broken down into a couple of components. Of course, when we first start to see you, in addition to doing your physical exam, we also need to get a history because it's important for us to understand where a little bit about your child's course, but then also about your family history as well too. Because understanding what the family history is helps us know if there are any additional risk factors to having possible cardiac or more severe cardiac involvement earlier on. The other part that's really important for us is the testing that we do. Next slide. So with the testing, that helps us really closely monitor how the heart is functioning, and it also helps us guide the timing of all of our therapies. So usually in a cardiac visit, we order the basic tests. So your echo, your EKG, and those help us monitor both the structure of the heart, how well it's functioning, and then the EKG helps us take a look at the heart rhythm. When your child gets older, then what we start to do is a little bit more advanced testing. So the advanced testing includes our cardiac MRI for imaging. The cardiac MRI gives us a lot more detailed images, and with that detail, we're able to do more precise measurements of the heart function. And then we're also, something that the cardiac MRI can do, but that the echocardiogram can't do, is that it can help us look actually at the health of the heart muscle. And so we can identify with the cardiac MRI whether or not scar tissue is developing and the degree of scar tissue that's developed around the heart. So we tend to do that a little bit older because you need to be able to lie still for that test. If you can't lie still, then it really alters the images. So the younger our kids are actually our like 7 and 8 year olds are really good at following directions, and our teenagers, God, they gotta move. It's like, don't move. But when you move, you have to start the cycle over again, and it can make a 30-minute test go into an hour and 30 minutes because they want to move a part of your body or scratch your nose or move your head. And it's, no, you can't do that. But they do have to be old enough to be able to do that test, and we don't do that test under sedation because of the risk of sedation versus being able to undergo the test. It's not worth it to us. The Holter monitor is another test that we use. It's like an EKG. But the Holter monitor they wear for a longer period of time. Some institutions do it for a day. We do it no more than 2 weeks. But the limitation of doing, we do that test because the EKG only tells us what your heart rhythm is doing at the moment in time that we're doing the EKG. But the Holter monitor gives us information about the heart rhythm throughout the course of a child's day. We do labs. The labs that we take really give us information about how stressed the heart is. The higher these values are, it tells us how much heart muscle tissue is being affected and then how much strain the heart muscle is undergoing. Next slide. So I just wanted to talk briefly about our carriers of Duchenne muscular dystrophy. Those tend to be our female carriers. So our females who have the genetic mutation, it's really important that you get screened as well too, if you have that, because although it may not manifest in your skeletal muscles, we have identified that cardiomyopathy can develop. So regular screening in our moms or sisters or women with the genetic mutation, it's important to also get a heart evaluation. I have had some families come back to me and say they really have a hard time getting their primary care provider to order the testing. That happens, unfortunately, often enough for me to recognize it or for me to remember that. And oftentimes they'll say, it's because the primary told me that I don't have anything physically wrong with my heart, so why do I need a referral to a cardiologist? Please let us know if you know anyone that's having that kind of feedback, because we can send the guidelines and that are very explicit in advocating for screening for our carriers. So typically once we're able to send those guidelines over, then it really moves a referral and an authorization process through pretty quickly. Next slide. So what else can you do? Medications. Medications are the mainstay at preserving heart function. You guys, I know that if you've gone to clinic, you've heard of these. We talk about it when we first see a family. It doesn't matter how young your child is. Considering medications is really important. There are 3 main medicines that we use initially in therapy, even when we're not seeing any dysfunction or any clinical weakening of the heart. The first is an ACE inhibitor or an ARB. They have really long names, so it's easier to remember them as ACEs or ARBs. They're very commonly used, actually, heart medications. You see it a lot in adults to control blood pressure, and I've had families come and it's like, my grandma's on that. It's like, yeah, she probably is. They work to improve heart function by decreasing the workload on the heart. It relaxes the blood vessels, so the heart just doesn't have to work as hard when it pumps. Beta blockers are used to slow down the heart. The faster the heart is beating, the more it's working, and there is a predisposition to have faster heart rates in a young person living with Duchenne's. So slowing down the heart rate means that the heart doesn't have to squeeze as often or work as hard, or because it's not beating as rapidly. And we talked a lot about the scarring that develops. The mineralocorticoids, and we abbreviate that as MRAs. The MRAs are given to slow down the progression of laying down that scar tissue. So it keeps the heart muscle more flexible and more pliable, and it kind of just slows down the whole scarring process. Heart disease is progressive, and eventually these medicines won't be enough. The heart muscle, when the heart muscle weakens to a moderate or severe degree, then there are advanced heart failure therapies that we employ. So even though the heart muscle is changing, there's a lot we can still continue to do, and more medications that we can offer that can help preserve the heart function for longer. And these medications also help our young people feel better. So when it's time to do that, those medicines are offered. Those are the really long names for them, but you'll probably recognize them by their trade names. It's like Entresto. I'm sure you've heard of it. They have commercials all over the place, and then Jardiance as well too. So I'm just mentioning it. I'm not advocating for it, but I'm just mentioning it because those are the medicines that were used, and they're easier to remember. Next slide. The most important thing is start as early as you can. The guidelines say the age of 10, but our experience has been that the earlier you start, the better the outcomes are. Next slide. So this is a slide that illustrates this. Medicines that were started early, the heart function continues to still decline, but you preserve heart function for a longer period of time, and that's illustrated in the red. Those that started medication therapies later had a much earlier decline in heart function and at a much more rapid trajectory. One thing that I also want to notice is the bottom of the blue line. This indicates longevity. Those that started medications later had shorter lifespan than those that started medications earlier. So if there's anything I want you to walk away with today is start therapies early. I know they're young, and when we're sitting there in clinic talking to you about starting your 3-year-old on heart medicines and you are not sure, I am not doing it for treatment of your child at 3 years old. I am thinking about your 16-year-old son, your 17-year-old son, and it makes a difference what you do the years before that. Okay, next slide. Gene therapy. I had a really great presentation on gene therapy. We are very involved in that. There are new guys, if your young person is a candidate for that, and when they receive it, you see a lot of us too, and a lot more frequently than your usual annual follow-ups. One of the things that can happen with gene transfer therapy is that the inflammatory process can also affect the heart. And so we watch really closely to make sure that the heart isn't affected during this process. And if it is, then we are there to help and intervene and closely monitor. I don't monitor as frequently as once a week for the first 4 months, but we are there. The guidelines now are 1 month after you receive it, and then 6 months, and then a year afterwards. So that first year, you'll see a lot more of cardiology than you typically do. Next slide. Even when the heart muscle gets really weak, there are still other options, and there are still other things that we can offer. When the rhythms, as the heart muscle gets really stretched, you have a propensity for abnormal heart rhythms, but then the heart rhythms that you're seeing can be more dangerous. So there are options for that, for controlling the heart rhythm and helping a person come out of an abnormal heartbeat. When the muscle gets very, very weak, there is also a machine that can pump the blood for the heart. That is not offered at children's. It's something that may be offered in adult therapies, but it's something that you may see as your child gets older into their adult years. Next slide. So living with Duchenne's, it's not just about longevity, it's also about quality. Next slide. And so there's a lot we can do. Really first is early intervention and early connection with their cardiology team is really important. The guidelines recommend at or around their diagnosis, they should already start to be seeing a cardiologist along with a neurologist as well. And then start medicines really early. That's also very key. The other thing that's also really important is make sure the vaccinations are up to date, because minimizing exposure to illness is also really important. We have seen that because the heart muscle doesn't have the same recovery, sometimes when a person who already has some declined function has a significant or a prolonged illness, the heart muscle itself isn't able to keep up, and the heart function will decline even once they've recovered from illness. So making sure that we're minimizing the severity of illness a person undergoes, decreasing their exposure or their frequency of illness is very key. Nutrition is also really important. Maintaining a healthy weight is really important. Either being undernourished or overnourished puts additional stress on the heart, and that's something that can really help prolong their heart function. It's not just about having medications, but it's about taking your medications. So make sure that you're adhering to the therapies as they're prescribed. And the other important point I wanted to make is that we all work as a team. So your other providers' therapies are equally as important for the heart. The things that Dr. Ramos-Platt and the neurology team are prescribing, the things that the respiratory team are prescribing, all support the heart as well too. And we work in concert with one another, so adhere to those guidelines. The thing that I wanted everyone to walk away with as well is that there are very minimal restrictions from a cardiac standpoint. There's a lot your young person can do. We don't restrict activities or social gatherings. If they want to do something a little bit more physical, it's okay with that. We're okay with that, because oftentimes the physical activity is it's self-limiting. And so they aren't going to do anything that's going to impact their heart. So I want your young people to be as active and to engage as much as possible. In summary, start meds early, see your cardiologist and your medical team regularly, and for those that are carriers, also get your heart screened. Next slide. Any questions? You want? Oh yeah, I don't want this.
Great job. Thank you, Cheryl. Thank you. I guess it's an understatement to say that living with Duchenne is complex, right? It's very complex. Just to say a few things, early detection is important. Early detection is important. Prevention and having a wonderful, comprehensive team that cares. And, quality of professionals. And so thank you so much. We do have a few minutes for question and answers. Yes, ma'am.
What are the signs of early detection?
And this is for the team of professionals. What are the signs of early detection?
So what we're hoping is that it's going to get on the newborn screen. They're doing work on that right now. And so that will hopefully be the earliest detection that we could. We're hoping to get it on the newborn screen. So that will be the earliest detection possible. California is going to consider that for the newborn screen. It is already on the newborn screen in other states. In a few other states, it's there. But it's exactly, what has been talked about so far. It's like a lot of times it's actually not motor. It's they have difficulty with speaking. And so that can actually delay diagnosis because families will go to their regular doctor and think, they're not really speaking, they're on autistic spectrum, and so the pediatrician or the family practice doctor might chuck up their weakness to autism. But not speaking is actually one of the first signs of Duchenne. And then there are certain things that our physical therapists can pick up on. So if they are toe walking, if they are falling more, if they stick out their bellies when they're walking. Dr. Abu Hamad showed you a Gower sign. When they don't just stand from a seated position, they actually have to climb up their legs and take many steps in order to stand. So those are some early signs of Duchenne.
Have you tried homeopathic options for the kids pertaining to instead of steroids?
We have not. Now, there have been some families that have opted for that, and the outcome was not as good. It's not to say, I grew up in Hawaii. I trained in Hawaii, and we use a lot of homeopathic for us, it's Eastern medicine along with Western medicine together. So there are things that you can do that can help the Western medicine part of it. And so that includes things like using spices that are known to be antioxidants. Cinnamon, turmeric, those things are helpful. We also know it also helps with liver health. But no matter what, it's not to say no to Eastern medicine. It's to say let's say yes, but let's work on it together.
How does it with gene therapy work?
Oh. So gene therapy, it's usually just a one-time dose. We put that gene inside a virus, then we infect you with we infect the child with the virus, and so then their cells will now hopefully take on a new DNA and make a new protein. And that protein is not perfect. And you don't get 100% protein. You might get something like 30% of the protein produced. But still, 30% is better than 0. And again, as Dr. Abu Hamad had mentioned, 5% is enough to get you into that Becker category. So 30% is pretty darn good.
I have a question. Ed Tepperson was up there. Josh was one of the first boys in California who received it and was part of the trial.
Mm-hmm.
What are your thoughts on that in reference to gene therapy? Because he's older, so gene therapy for us is kind of like it's not broken, so we don't really want to, change his treatment because he is doing so well on the EXONDYS 51. Do you believe that it's kind of like the same, but the 51 is more short term, right? Like 7 days, he has to get another infusion.
Mm-hmm.
When the gene therapy is like one dose and he's good. How do you think they level to each other? Your opinion, I know it's.
Yeah. No, I actually have a family of 3 boys that they decided the same thing. They decided that, eteplirsen was good for them and they didn't want to, take the gene transfer therapy. But they both produce a smaller version of the gene, of the protein. But when we talk about eteplirsen, we're talking about a few percentage, just like, 1 to 5. Yeah. If you look at that clinical trial versus, the gene transfer, again, also a shortened dystrophin, talking about like closer to 30.
So they don't know about data on the older boys.
You are correct.
Why we're kind of like very hesitant.
And that's the same reason why some of my older boys have decided not as well, because they're saying that in the clinical trial there were 8 boys.
And you have to wash out from that too, so he won't be able to do his. It's just a lot. It was a lot to think about. It was a very hard decision.
Yeah.
Ultimately, it was his decision. He's older now, so. But I just wanted to know where you thought it was.
Yeah, it's something. Again, I will, especially that I'm an advisor for both, right? But the way that it's always a decision for the family. I can guide you, I can give you the data, like we can give you the data, but in the end, it's what works best for you. Like I had a child that decided he did not want it because this was his life. He was already doing well with what he had. He was in college. Did he want to take that risk of some of these side effects? And he did not. So that was his decision. Yes.
The one I have already.
There's nothing wrong with that.
Yeah.
Do you think that the larger the lesion in the DMD, would that translate to later on in life the boys progressing faster?
Not necessarily, because if you look at the construct of the gene transfer, that's maybe like 1/5 the size of the typical of the whole gene, but they just took the most important parts. So not necessarily. There are some people that they're just missing 2 exons, and yet that's a lot worse than what we see with some of our much larger exons missing.
Yes.
I don't know if it's for, well, I think, I don't know, are you familiar with Diamox?
Mhm.
Okay, so Josh is on like a Diamox medication, and I seen
Oh,
on
she
cardio,
needs it. She's
on
too.
cardio, you guys mentioned that she should be on like a spirolactone, which she was. The Diamox being another form of like a diuretic, correct? It kind of works the same way. We're having trouble with putting him on both because he gets very ill. So is there other options for that kind of medication, or do we ultimately, you think, have to take him off of like one medication to get the benefit, because we'd rather have the spirolactone?
That's a
I
really-
see it on the chart.
That's a really good question. Oh, yeah, that's a really good question. And I'll be upfront. It's like I have not, yes. So spironolactone and eplerenone are both mild diuretics. And it is possible that a child may not tolerate being on both diuretics because of the water loss or the fluid loss with that. I don't know Diamox as one of the therapies that helps slow down the changes in the heart muscle. So that would be something that I would need to take a look at to know. Oh,
He got the pseudotumor.
okay, okay.
Or he did the growth hormone, and he got it from that. We found out, so it's just the papilledema and stuff like that. So
Okay.
we're trying to take him off one, but his body just can't get off the Diamox. So I think it's something we have to work with ophthalmology, neuro, and maybe our
And cardiology as well too, so that we can work together to find an optimal therapy for him, because maybe it could be dose dependent, and we may be able to reduce the dose so that he can still have the protective effect without having the additional side effect of the diuretic effect of the spironolactone.
It doesn't work. Because that's something is kind of like Diamox,
exactly.
but it also does the weight thing. Some of our kids are tough for the weight.
I think we'll switch.
Okay.
I think we'll switch back to CHLA. Yeah. So, we'll see.
Okay. I hope that helped. It's okay. Okay.
I had a quick question. When you talk about a medication for the heart, how do we determine what medication works? I mean, is it a trial? So okay, this may work, and this may just slow heartbeat or it increase the heartbeat. What is determined what type of medication?
Okay. So it depends on a couple of different things. So you talked about like the rate of the heartbeat. It depends on the effect that I'm trying to achieve, because the medications, depending on which one you start, one of them affects the blood pressure more than the other one. They both affect the rate. So specifically for beta blockers, both affect the rate. But if I'm also trying to lower the blood pressure, because the blood pressure is a little bit higher than what's optimal for what we're looking for, then we'll choose the medication that lowers the blood pressure. The other thing that's honestly that I also take a look at is adherence to the therapies. If that's not a question, one of the medications for both of those, both in the ACE inhibitors and for the beta blockers, each of one of those classes or each of one of those medications in those particular classes are twice daily dosing. And it's hard for families to remember when you take so many medications to take that second dose. And to really optimize therapy, it's really important to do it. So if a family is having some challenges with taking twice daily dosing and the blood pressure doesn't matter, then I'll switch them to the single dose or the single day dose. Yeah, but when we're making decisions about which therapy to start, we are not just looking at one particular aspect. We're looking at the total child and how we can combine medications to achieve the effects. Yeah, that's a good thing. And I often have questions about that. Is it safe to start these medicines together? It is. They're often given as a triad later in therapies, but we start them in layers. So it typically starts with the ACE inhibitor and the ARBs first. Then looking at whether or not we're seeing an elevated heart rate, we'll decide whether or not to start the medicine that slows the heart rate, or if the heart rate is exactly where we want it to be, then we'll start, if we see that tonic contraction, so that shrinking of the heart muscle chamber, we call that tonic contraction. If you read the literature, sometimes they call it hypertrophy because the heart muscle might measure a little bit thicker, but the heart chamber is smaller. Regardless of what description they're using, when we see that, we really push to start the mineralocorticoid or the MRA, because we already know that it's going to, the next part of that is leading to the scarring. The reason that the heart muscle is contracting like that is because of that leaking of the interior contents to the outside. It has an electrolyte in it called, well, it's calcium, right? So the calcium leaks into the extracellular space, and that causes the heart muscle to contract, and it doesn't relax. And so that's why. I can see it on an echo. So no, because what I'll look for is I'll look at we call it a Z-score, and that score is like what's on average for someone this age. And if it starts to measure smaller than what's average, then we calculate that, or we mark that as, oh, you're starting to show signs of tonic contraction.
I have a question, yes. It has to do with older boys, and I know we don't have an endocrine doctor here, but I want to talk about how you introduce or the effects of testosterone with the medication that they're taking now. I want to, maybe a little bit more about that, because, the boys do get older. Some boys need testosterone, some don't, right? So I want to know a little bit more. What are your thoughts on that? Because you see them.
Yeah, it's actually on the guidelines. So we usually will start talking about that. So the old guidelines were by age 16, you don't see any pubertal development. That's actually gone down. So now we're down to 14. I think a lot of us are now looking at it at age 12. We will then refer over to endocrinology, and there's other things that testosterone can do which are helpful for boys. Again, I'm not an endocrine doctor, and I don't play one on TV, so I don't know all of this as well, but it does also somewhat help with a little bit of their muscle, so they do have a little bit more muscle. And then psychologically, I think it helps, especially our teenage boys who don't want to look like they're 7. So we do recommend it.
Thank you very much.
Thank you. Okay, we are on schedule. I would like to introduce our next guest speaker. His name is Andrew Skinner, and Andrew is here with the Triumph Foundation. They're providing hope, resources, and security to people that are living with paralysis. Welcome.
Thank you. You want to put it on?
Yeah, of course. There you go.
Yeah, I won't use it. Well, hi, everybody. Thank you. It's really an honor to be here for the Hunter Heart Foundation's conference. One second. Thank you, Karen, for inviting me. So yeah, I'm Andrew. I'm the founder of Triumph Foundation. I have a spinal cord injury, so I acquired my disability. I became a quadriplegic from a snowboarding accident, and it was really a tough time. Obviously, life took a radical change that I never saw coming, and I thought I had lost everything, and everything was devastated. And I was very fortunate that I had a wonderful family that was there to support me. And they encouraged me that it didn't matter how long I lived or what I was physically able to do. What mattered was how I lived. And so I was just focused on being the best me that I could possibly be and trying to make quality of life a reality and get out there and live life to its fullest capability that I had. And so Triumph Foundation has kind of a special focus on spinal cord injuries because that's what happened to me. But we got love for everyone, especially our friends with Duchenne's and other forms of muscular dystrophy. And we don't care who you are, what your ability is, you are welcome and you belong with Triumph Foundation. And so we've got a few programs I just wanted to highlight for all of you in case you're looking for resources and looking for help. And first of all, if information's your drug, we are your dealer. And so we have lots of resources that are really just practical, navigating government assistance programs. Where do you find, help for school? Where do you go for assistance? In all different ways. We have an extensive list of grants that are out there. I can go on and on and on, but I have a wonderful resource guidebook that I brought today if you guys want to check it out, that I can put out on display, and a lot of it's on our website too. And it's, kind of cuts through a lot of the bureaucracy that's out there. Sometimes you look into these government assistance programs and you get tied up in all their gobbledygoosh of just keep it straight, keep it candid, get straight to the point. And so we try to, arm you with some information that will be helpful. Secondarily, we have a robust equipment repurposing program. We call it the Exchange. And so a lot of people have equipment that they either grow out of or they got a new device or what have you, and they just want to give it to somebody else and bless them with it. And so we have on our website a tab that says Exchange, and you can find all sorts of medical goods and supplies that people are giving away. So before you buy something, you might find someone giving away a short 5-foot ramp or some other power device or what have you. And obviously, as you guys might collect some stuff in your garage that's just collecting dust, a good way to repurpose it is by posting it up on our website, and you can give it away to somebody else that does. And it's pretty easy to use. You just create a quick account, you post the item up there, and then people would respond through its portal, and you'd get an email saying, hey, I'm interested in this, and then you can decide if it's a good fit. And then they can come to your house and pick it up, and then you don't have to worry about it. Make sure it goes to somebody rather than ends up in a landfill or what have you. But there's lots of free stuff that's out there, and just trying to connect the dots within the community. And then last but not least, I want to highlight that Triumph does all sorts of community activities. Pretty much wouldn't it be fun if, and you fill in the blank, and we do it. And so just about every weekend, Triumph has some sort of activity going on, from traditional kind of wheelchair sports like basketball and rugby, which is my favorite sport, which is like bumper cars and wheelchairs, to archery. We do power soccer. We do tennis. We do scuba diving. All sorts of activities that we adapt, and everyone can play. So we have a special focus on just inclusivity, and so when you come out to a Triumph event, you won't just watch your son or daughter or a family member play. Your butts are getting in the game too, which makes it really, really special. So I have lots of things that I could plug, but just a couple of them briefly. So coming up next weekend, so not this weekend obviously, but next weekend, the 26th and 27th, it's all day, both days. We have a wheelchair sports festival. Now it's way out in Santa Clarita, kind of by Six Flags Magic Mountain, but it's worth the drive. And at this event, we'll have 15, 16 different activities that are open for everyone to play. It's all free, it's all inclusive. And like I said, it'll have wheelchair basketball, it'll have power soccer, it'll have archery, it'll have baseball, which is over the line where you're just hitting a baseball with a wiffle ball bat over a certain distance line, and the other team has to field or catch the ball. And for people like me that don't have great hand function, all we have to do is touch it, which kind of gives us the advantage, which is really fun. To skate park, we get the kids out there, people are using a manual wheelchair to learn how to roll down a hill without mom or dad holding them, to the big stuntmen doing big tricks, and even to just power chair users. We have several different activities, from rodeo is what we call it, which is like an obstacle course that we have them race through, and we time everybody, to kind of a drag race where people have to race down and around a cone and back. To all sorts of I can go on and on about this event. We'll also have art and dance and music, and it's really, really fun. Like I said, it's all free. I'd encourage you to please register so we know how many hot dogs to barbecue that day and how much pizza to order, because we'll feed you too. But there's events like this going on all the time. This happens to be our biggest event, so when Karen asked me, it's like perfect timing because I can push this event, and it really can be life-changing for a lot of people. Obviously, we want to find treatments and ways to care for our loved ones that might be dealing with some health issues. But I also think that fine line of getting out there and doing something fun, making it the best day possible, right? And just know that you're always invited. Like I mentioned, we have the Wheelchair Sports Festival, but we also do another one in November. It's at the Rose Bowl. We have a baseball tournament. We have cycling rides. So we have, and by the way, at all these events, we provide all the equipment. So you don't need to own your own chair. You don't need to know how to play. Just show up. We'll have coaches there. We'll have all the equipment there, and we'll teach everybody how to play in these games. But we're always doing something fun, and we have a special place in our heart for kids. And so at these events, we have a youth camp. And so it's not really a camp where you stay overnight, but you'll just get kind of a special chaperoned experience from one activity to the next. So all the kids get to play together, which makes it kind of fun. And we try to have camp counselors so the parents you can hang out on the sidelines and let the kids kind of go about and do what they want to do. I just want to get people out of the house and doing something that lifts their spirits and builds those community connections. We have, support groups too. That meet up regularly. We're kind of a traveling circus, so we hold everything from Santa Barbara down to San Diego. So again, if you're not from LA, 1 month we'll be up in Santa Clarita. I think next month we'll be in Orange County. We're planning an event in San Diego in August. Obviously everywhere in between, to the Inland Empire, to the beaches. And you're always invited. Even if you don't pre-register, which I want you to, obviously, just show up. Just show up. I know some days are better than others, and you're like, oh, I didn't register, I don't know. 99% of the stuff that we do, it's just come out and play, with the exception of when we go snow skiing. You do have to reserve your spot. We'd love to get your kids up on the mountains. We do that a few times a year, and we always give preference to first-time skiers, get to go first, and we subsidize it heavily, but we can't just have 500 people show up to go snow skiing. It's limited to around 10 spots. And similarly, there's other activities from fishing and other things that you do have to kind of put your name on the list. Same thing with scuba diving at the sports festival. So you had to be pre-registered for that, but that can be a next year's goal. And we work with some wonderful programs. So it's not all Triumph Foundation. We partner with the Hunter's Heart Foundation. We partner with programs that do these various activities and bring everyone together to put on something fun and meaningful. And again, all inclusive, so the families, the brothers, the sisters, the friends, whoever comes out, all gets to play hard and have fun. And ultimately, I just want to be a resource to you. I feel like God has a purpose greater for your life and for mine, greater than I ever imagined. When I found myself in this situation, I felt lost and felt like, why me? But I found so much joy in my life that I don't think I would have ever discovered had I not gone through this. And so just to keep hope alive, that there is meaning and there is purpose, and it might take time to find your way. But I feel like just being amongst other people that have that similar heart and that fellowship will hopefully help you find whatever pathway that you're supposed to be on will be, and then connecting with other people that'll have that positive energy and that hopeful spirit. So I go on and on and on, but do you guys have any questions or anything like that you guys want to throw at me? I'm happy to answer. Hi.
What's your event in Orange County next week?
So it's not next week, but so we just did cycling a few weeks ago for April. So we're planning a 5K. I know Hunter's Heart does their 5K. We'll have a 5K down there. We also do a baseball tournament down there. And then we're trying to put together a sports festival that'll be somewhere down there. So we're kind of working out those details. But on the same note, if you follow our website, we're also promoting lots of other activities. And so I don't know what you're into or what your family's into. But that same thing goes to if you guys have stuff that you want to share. Our event board, like anybody can post their stuff up there. We try to make it real easy. And again, we want to be that community bulletin board. But is there something you're looking for specifically?
No, I work with a Duchenne advocacy organization based down there, and I want to make sure we connect because
Yeah.
I would love to share this information.
Yeah. I mean,
And include you in what things that we do.
And I can name off a couple other programs that do stuff regularly too. At Bolsa Chica, there's a cycling program that happens on the second Saturday of every month, and it's similar to ours where they provide all the equipment and you can just come out and go cruise along the beach. It's called Ramp. There's an extensive list in here that I can arm you with. And then again, we do just some, just get-togethers where we'll do like push along the beach or stroll on the beach together. And it's kind of exercise and kind of that social thing and kind of that support network. And that takes place a lot of times in Huntington or Newport and places like that. So each month's a little bit different. But any other questions or anything? You guys are easy. My honor. My honor. Yeah, I won't like that.
Andrew's a really great guy. I met him when Hunter was doing wheelchair soccer, and one of the moms told me about him. I would watch his website and look at it often, but he said yes immediately, and it's just good to have these type of resources for your children and for your family, and bring your whole family out and just do things together like he said, and I'm just thankful that you came down to share. We won't be there next week, but I'll see you in the future.
So I forgot so Power Soccer, I'm sure Karen's told you, but it's every Sunday in Burbank. We have rugby, fencing, and Power Soccer going on.
Yes.
And again, it's open for anyone to come out and play. And then we're hoping to help develop a Power Soccer team down in the San Diego area. And that'll be part of our event that we're doing in August, August 16th. So it'll be Oceanside.
Okay, perfect.
Oceanside, August 16th. I beg your pardon? No, so look, she's asking about surfing. So a lot of these sports, like if someone else is doing it, why reinvent the wheel, right? Let's just partner with the people that do an awesome job. And so there are a bunch of surfing programs that I can get you plugged into. I love that sport too. And a lot of times, even if you don't play, just being there is awesome to see people, have that awesome stoked, face when they come out of the water. And so sometimes I'll just go to be a participant and more of a spectator. But
So will you be here a little longer in case people want to talk to you
I'll
up front?
hang out a
Okay.
little bit.
All right. So we're going to take a break right now. I think it's lunchtime. I need to check to see if everything was delivered. We know the kids have their lunch, but I don't see our lunch. So just give me a few minutes and we can bring up Nicole and Josh. Oh, no, we're going to take a break, right? Let's take a break, stretch our legs, go to the restroom, give me a minute, come back, and Seema, what's our time that we're coming back? 12:15? Okay, 10-15 minute break. How about that? We'll see everybody in 15 minutes for lunch. All right? Thank you. All right. To Shin, to Kaiser, to Triumph Foundation, to my family, to everyone that's here that came out and supported us. The energy is really, really good. Each year we get better and better, and I'm thankful for that. I'm grateful for that, and I could just see us really making an impact in the DMD community. And I tell people, even if you don't know a family member, you'll be prepared when you meet a family member with Duchenne muscular dystrophy. So it's really important for us to continue to spread the word and to advocate and create community. Community is really important. I remember my grandson, when he was 10, he's 20-something now, and he was in the living room, and he was talking to someone. And I said, well, who are you talking to? And it was just he and I. And he said, I'm talking to my friend, Granny. I said, where? He said, I'm talking to my friend. And I learned about the headphones where they could socialize, right? I'm going like, oh, okay. So, you know, I allow her to play a little bit more than the average kid, you know, but I still monitor. But connecting with their friends is so important. And so we want to keep this going. Thank you so much for coming. I really appreciate everyone. So at this time, without further ado, I'm going to call him David, and I don't want to mess up his last name.
Listen, everyone
Okay, Mr. David M., right? From Kaiser, right? Thank you. This is for you to put on?
So this goes on me? Okay.
Yep, that goes on you. I think you're ready.
Yeah.
Okay.
Hey guys, good afternoon. My name is David Makayawan. I am a physical therapist by trade. I am the Assistant Director of Rehab Services for Kaiser in the Downey region. This was just by luck of the draw for me being here. My boss's boss comes down and he says, hey, do you know anything about Duchenne's? I was like, oh yeah, dude, that was my senior paper in PT school, you know, many years ago. And he said, volunteer. And I'm like, all right. But anyway, great to be here. That paper that I wrote was many years ago, but it left such an impact on me that even till this day, I still know the statistics. I still know the disease etiology, how it progresses and such. And you know, the fact that we have this, like the resources that are provided for you guys, I think it's so awesome, and I'm very, very happy to be here. So I know I have 15 minutes, so if I talk too fast, let me know. So that's who I am. All right, so this is what you have up on the screen. That's kind of like the PT approach for DMD. And I'm just going to touch upon each point. So first thing we want to do is educate folks on, like, what are the precautions? What should you not be doing with family members who have DMD? What should you not be doing, and what you should do? So we definitely educate on precautions. Before I go any further, how many people here are care providers for folks who have Duchenne's? Okay, perfect. So definitely would apply to you guys. Physical therapists, we do exercise and conditioning. We want them to be as strong as possible. We want them to be as flexible as possible. And we want them to have the best endurance they could possibly have. So when it comes to exercise, I highly recommend, if you're not doing it now, and they probably are, see a physical therapist, because they can tell you based on where the child is in the disease progression, what to do and what not to do. So it's very individual. So it's very individual. So definitely consult with them. But I will talk about exercises that have already gotten the green light for everyone. Okay. So stretching is very, very important for folks with DMD, just because of the disease progression. A lot of time the muscle becomes fibrosed, it becomes scar tissue, and unlike native tissue, unlike native muscle tissue, that scar tissue isn't very flexible. So there's a high chance of developing contractures. Contractures are when joints can get stuck in a certain range of motion. They don't move well. So very, very, very important to do your stretching. And then lastly, we like to push regular evaluations. There's a certain type of progression with this disease, and it's very important that we monitor it so that we know if this child needs a certain piece of equipment, whether it be bracing, whether it be crutching, whether it be wheelchair devices. So I would highly, highly promote regular evaluations for folks who have this, okay? I was thinking about my audience, thinking about you guys. I'm like, okay, I got 15 minutes, so what do I talk about? So I want to talk about the things that pertain to you, not so much in the clinic, but to you guys when you're at home with your loved one. So the first thing we can do is we can really focus on muscle tissue preservation. For those of us, and I know this is probably review for a lot of you, but when the muscle breaks down, it doesn't come back, okay, for folks with DMD. So you have to be cognizant of that, you have to be aware of that, and you have to play it safe. So things to avoid: high impact and explosive exercises, running, bounding, jumping, especially newly diagnosed folks. You gotta, once you know they have it, you have to try to keep away from those activities, only because they will break down the muscle. And as I mentioned, it's very, very difficult to build that muscle back up because of the nature of the disease. Heavy and high intensity loads. We don't want them lifting heavy things. Again, another opportunity for the muscle to break down. We want them to avoid that. Excessive exercise volume. Even though, like, let's say for pool training, they say pool is really good for, this population, but there is such a thing as doing too much in the pool. So you have to be aware of that. And then lastly, I'll touch on that one. It's a little bit complex. I mean, for eccentric muscle contractions, that was like a 2-hour lecture in my undergraduate, physiology class. So I'll touch on it and I'll try to make it as simple as possible. But there are certain ways to contract the muscle. One in which, if you're lengthening the muscle under resistance, that is not good for the muscle because there's a high chance that it can break down muscle faster than a concentric exercise. Like I mentioned, I'll get into it shortly. Okay, when it comes to muscle or tissue preservation, it's very, very important. When they're not in the clinic, you are monitoring their activities. You need to know what they're doing, how much they're doing, how hard they're doing it. Because if you do, so let's say, for instance, you go out to the pool, you let the child play in the pool for 25 minutes, the child comes back, complains of excessive fatigue, complains of, oh, my elbows or my hips hurt. If you document that, you'll know what to do or what not to do the next time you're in that situation. So that's usually not the first thing that comes to mind, but I think with this population, it's very important that we monitor and document, okay? Know the frequency, know the intensity, so that if anything happens, joint pain, excessive fatigue, you'll know what not to do when in the same situation. Does that make sense? All right. Okay, so going back to the eccentric contraction, I'm going to try to make it as simple as possible. So if I take this pen, let's say this pen weighs 50 pounds. I'm going to do an arm curl, which affects this muscle. This is my bicep. So this biceps muscle is working, but it's shortening. Now, that's what we call a concentric contraction. As I slowly lower the weight, this muscle is still working to control that weight on its way down, but the muscle is lengthening. Now, that's what we call an eccentric contraction. That's a contraction that you kind of want to watch out for, especially if the child is carrying load. We like to use the term load. It's just another way of saying weight or resistance, okay? One simple way to look at it is this way. If gravity is the source of resistance, the descent or the lowering of whatever it is that you're lifting, could be your own body weight, the lowering part is an eccentric contraction. Does that make sense? So as I lower myself into this chair, muscles are getting stretched while working. That's an eccentric contraction. It may not be a big deal when they're still very functional, but there will be a point where you'll have to hold their hands or hold their trunk and slowly lower them and help them to slowly lower because it'll just put too much on the muscle, okay? So does that make it easier, that explanation? When gravity is involved, the part where you're lowering is the part where you're doing an eccentric muscle contraction. Try to watch out for that, okay? Walking down hills or descending stairs, a lot of the times I promote like, hey, even though they can walk, going uphill, no problem, but always have maybe a transport chair or a wheelchair handy, so the downhill component, you can help them by putting them in the chair and allowing them to go downhill in the chair, not being exposed to those eccentric contractions. Now, life, guys, there's going to be times where we can't avoid eccentric contractions, but just in the big sum of things, do what you can when you can, okay? And then I would highly recommend that you look it up. There's plenty of literature on eccentric contractions and activities to avoid. If you have any questions, I'll have my card out. You can get my card and I can dive into it a little bit deeper, but definitely something you want to avoid. And then one thing that I also have there, resistance bands, right? Everyone knows resistance bands. So when I grab that end of that resistance band and I pull it towards me and I stretch it, that's a concentric contraction. It's good. But as I slowly bring it back and control it as it retracts, that's eccentric. So things to be aware of, things to avoid, especially when the disease gets to the point where simple movements like that make a big difference and could definitely hurt them, okay? And here's my demonstration. Okay, recommended exercises, biking. and you'll see it's promoted, that exercise or that activity has a green light for this population. Hand cycle, right? How many of you have hand cycles or use them for this population? They're great because they allow you to use the arms without any eccentric contraction, okay? Arm cycles, stationary bicycles, green light, good for this population. Active assisted exercise, that's just a fancy way of saying, I help you while you move. Okay, so if you can imagine, you don't mind being a model? Okay, so she's gonna sit here, so she's gonna raise her arm overhead. Okay, raise your arm overhead. Active assisted would be me helping her raise it overhead. She's still turning on her muscles, but not to the same degree without my help. And then we're gonna bring it back down. Okay, raise your arm up, I'm gonna give you help. So that's what they call active assisted. Doesn't seem like much, but it is a lot for this population. Thank you. Okay, that makes sense, guys? Aquatic exercise. Now, I had a discussion a moment ago about aquatic exercise. The pool is a great environment for this population, but you have to be careful. At most places that have water therapy, they have the water dumbbells, right? You guys see that, the water floaty dumbbells, not the plastic ones that can sink. Those are good, but the ones that float up to the surface, you have to avoid activities where the child is pushing those bells under the water. Because pushing the bells under the water, the part where the bells come back up and they're controlling it, that's an eccentric contraction, and that could do a little damage to the muscle tissue. So being in the water, moving in all sorts of directions, that's okay. Sitting on a noodle, that's okay. Now, using those floaty dumbbells to stay above the water, that's fine too. But doing the act of actually pushing it down underwater, no bueno, don't do it, okay? Or avoid it. Considerations for exercise, we want to make it light. We want to make it body weight or very light resistance, just to focus on turning on the muscle. There are some studies that demonstrate that simply turning on the muscles allows them to function better, okay? So when you get to a state where the disease has progressed, where the child's having difficulty moving, you will see a difference. If you take them into the pool, have them activate all the muscles, then put them back on land, they will be moving better when they get back on land. So muscle activation is key. And then lastly, I mentioned muscle activation. Okay, and here's a picture of the aquatic exercises. So if you notice, this is the gentleman at the bottom, my left, right? He's using the flotation device now. He's not pushing it under the water. It's just keeping him afloat, right? It's keeping him afloat. And with these, oh, he doesn't have a dumbbell, but see the young child in the top left or top right corner, the child's not pushing the dumbbells under the water, right? You see that? Moving it side to side, fine. Pushing it under the water, not so good. But again, highly encourage the water. Now, if you see the water dumbbells, these are the approved dumbbells. You see the green one and the blue one here? They sink under the water. They don't push up, okay? So those would be perfect for this population if they were gonna do movements under the water. Stretching. I touched on it earlier. Stretching is very, very important. As time goes by and the disease progresses, a lot of the muscle tissue is going to be replaced with scar tissue. We want the child to maintain their range of motion, so stretching is highly recommended, and I think they passed it out. Did you guys get that little packet? There should be, perfect, good. So recommendation is 5 to 7 times a week. Do the stretching, but do it lightly. Longer is better. I know the recommended duration I put is like 30 seconds to a minute. If you have more time on you, longer is better. Slow and steady, no jerky movements. You could damage the tissue by bouncing on it, right? So don't damage the tissue. Take it slow and easy and pain-free. Have that communication with the child. Hey, does this hurt? Do you feel the pull? Is it okay? Have that communication while you're stretching. And it's a great opportunity. When I work with my patients, if I'm stretching them, that's my opportunity to catch up with them. How's your day going? What have we done so far? Great time to kind of bond with them and communicate with them. Okay, so stretching, very important for this population. Keep it pain-free and always keep your eyes open, because a lot of the time communication isn't always best for the younger ones. They don't tell you everything that's going on. So just watch, are they wincing? Is there anything swelling? Is there discoloration in the joint? So definitely things to watch out for. Okay, so I want you guys to remember this. Breathing. Breathing is very important because towards the later stage of this disease progression, breathing can become difficult, right? They lose a lot of, lung capacity and such. So this is what I use to remember this type of breathing. I brought 4 quarters to the 7-Eleven to buy a stuffed octopus doll. Okay, so that's 4, 7, and 8. 4-second inspiration, that means you will inhale slowly for 4 seconds, you will hold it for 7 seconds, and then you slowly exhale for 8 seconds. Okay, so they call that 4, 7, 8 breathing. Excellent for developing lung capacity. When you do this, you promote diaphragmatic breathing, right? Imagine that you have a balloon in your belly, and then as you inhale, you're filling the balloon. Okay, and then you hold it for 7, then you exhale for 8. And there's one other component, I don't think you have to do it, but they recommend, touch the back of your teeth with your tongue as you exhale, right? That's supposed to center you. So in addition to helping them with their breathing capacity, it also decreases anxiety, it decreases stress, it lowers the blood pressure, it lowers the pulse. It's not just good for them, but it's also good for you. Okay, because I could imagine, I am a caregiver myself. My wife has an incurable disease. We've multiple surgeries, failed organ transplants and such. I get a lot of anxiety, but doing something like this really, really helps me to kind of calm down and center myself. So highly recommended, not just for the caregiver, but for the patient or for the child as well. Okay? So let's do it. Let's do it one time. Okay, so posture is very important because posture, that's also a big component of maintaining function. So I want everyone to sit up. Okay, sit up, nice and tall. So I want you to breathe in through your nose for 4 seconds and imagine filling a balloon that's in your stomach. Okay, get ready and go. 1, 2, 3, 4. Now hold it. We're going to hold for 7 seconds. 3, 4, 5, 6, 7. Now slowly exhale for 8. 2, 3, 4, 5, 6, 7, 8. Perfect. That's one cycle. So you would do that 3 to 5 cycles. Again, not just good for them, but also good for you. Okay, and then one component that I didn't mention, you also want to try to take yourself into a state of mindfulness, just really focusing on your breathing and not so much on everything that's happening around you, right? This will help you to center yourself, right? So good for breathing, good for times of stress. And I think my last slide, this is about you guys. You need to take care of you. Me being a caregiver for a family member that I love, I know things can get stressful, you can get overburdened, but you have to realize, what would they be without you guys, right? So you need to take care of yourselves, okay? So address your needs from physical, mental, optimize your diet if possible, optimize your rest and recovery, exercise. Those are things you can do to kind of take care of yourselves, because without you, where would they be? Okay? Also, too, that I want to mention is the fact that your attitude, right? Your attitude is huge. There are studies that demonstrate that, outcomes. Outcomes are much more positive when approached with a positive attitude, right? And a positive outlook, as opposed to the opposite. If you have a bad attitude, it's not likely you're going to get a positive outcome. So these are things that we have to do. We might as well, go at it with positivity, be optimistic so that the outcomes are much, much better. Have an attitude of gratitude. We get to make their lives better. Who better to take care of these people than us? And that's why you're here today, right? For your loved ones, your family members. No one's going to take care of them better than you, but you guys have to take care of yourselves. And the last thing is about, if you see that last sentence I have, houseflies live 21 days, right? Houseflies live 21 days. But to them, it's 21 days to us, but it's an eternity to them because they live in the moment, right? So you can take this breathing exercise to live in the moment. More so for your loved ones, but also for you, right? And then you can be an example. We only have so much time on planet Earth, whether you have a disease or whether you don't have a disease. learn how to make the most of it, live in the moment, be an example for those who may not have as much time as you. Okay? And that's it for my talk. Thank you guys for your time, and hopefully we got something out of it. I'm going to leave my card if anyone has any questions, or you feel free to reach out to me, and I'd love to reach back and give you whatever information you need. You're welcome. Thank you. Oh, yeah.
All right, thank you, David. And coming up, we have the following presenters you're gonna love. This is a fun part right here. This is a fun part. Let's get going. We have Raven Baker from the Painted Turtle. Hi, Raven. All right, Raven. And then right after Raven, we will have Hunter. Hunter is going to read his story, Hunter's story, Life with Duchenne Muscular Dystrophy. And then after Hunter, we have one of our DMD family, Nicole and Josh, that are going to come up. So I'm going to go ahead and just give them the mic, and we're going to start with Raven.
Hi everyone, my name is Raven. I'm the hospital outreach coordinator at the Painted Turtle. You may be wondering, what the heck is the Painted Turtle? Are they painting turtles? No, we don't actually paint turtles, but we do a lot of fun things. We're a camp for kids that have serious medical conditions. So we put on summer camps and family camps, and we actually have a session that is just for kids with muscular dystrophy. It's a 5-day summer camp. You can go ahead and go to the next. That's okay. So our muscular dystrophy session is taking place June 29th to July 3rd. It's in a lovely oasis in Lake Hughes, a small little town out near Santa Clarita, Valencia. So like an hour and a half-ish on a good day of LA traffic from here. And we service ages 7 to 17 for summer. And then we also do have a family camp, and that starts at ages 6, and we can see them all the way until they're 17 as well. A little bit of background about our camp. We opened in 2004, so last year was our 20th summer of servicing 200,000 kids up at camp. It was started by Paul Newman, so we're a part of a network called the Serious Fun Network. So there's about 30 plus camps in this network that's across the United States. We have a bunch in other countries, so all servicing children and their families, all free of charge, where they get to come to camp and get the full camp experience, but with parents not having to have the worry of who's going to be taking care of my child. Are they going to be able to have their medical care? Because we do have a medical facility that's on site where we have like doctors, nurses, OT, PT, nurse practitioners that are all there 24 hours a day while they're up there at camp for the summer. Next one. This is just a little overview of our map that we give when families arrive. So we have like our cabins, we call our medical facility the well shell because it's shaped like a turtle on the outside. So inside of the well shell, it looks very campy. All the rooms like have different themes. Does not look like you're gonna be in there getting some type of like medical procedure or anything done, because it's very campy and fancy. And all of our like medical team, they wear camp outfits. You really won't see them wearing many like lab coats and things like that. They're usually in like fun camp t-shirts, funky hats and things like that. We have a lake, we have an accessible ropes course that we're able to take a full wheelchair across, arts and crafts. We'll show some photos in a second. Go ahead. So you may be wondering, where do the kids sleep when they're at camp? We have beautiful accessible cabins where kids are on one side and they are assigned, like one of our staff stays with them on that side, and then they also have a nurse that's assigned to them at night. And they get to live in these beautifully cool cabins with beautiful bathrooms, air conditioner, running water, very much glamping. When you say the word camp, you're getting all the good stuff of still being at home, but a little bit of roughing it of being in the outdoors. what do our campers eat? We have a beautiful, fun dining hall, so we do all meals together. So that's with all of our staff, all the kids, they all eat together. We serve an array of items that our wonderful kitchen cooks up for us, breakfast, lunch, and dinner every single day. Just some examples: pancakes, waffles, tacos. We do what we call no-hands spaghetti meal. So this is where everyone eats a meal of spaghetti and we don't use our hands. We just use our faces and we get really messy and it's a lot of fun. All of our staff do it. Everyone really gets into it. And then we do accommodate any dietary needs that anyone has, gluten-free, vegan, we do it all. And then here are some of the examples of some of the activities that we do. We have some photos. So we have like arts and crafts, archery, boating. We do like a big opening campfire on the first night where we like roast marshmallows and we do skits. We have a wood shop. We have a stage night where kids display whatever talents they want. Sometimes we have kids that go up there and they just give us facts about baseball, or they sing, or they're like do something together as a cabin. We have a swimming pool, we have horses, we have a ropes course that is accessible to get an entire wheelchair across our ropes course. And we have what we call giant swing, where we have a really cool like harness seat that kids are able to do our giant swing in. Lots of fun. They will be very tired at the end of every single day because there's stuff going on all day. And then here's some photos of what the inside of our well shell looks like. So that's an example of what like one of our like exam rooms would look like. And then like I said, 24-hour medical care is there with nurse practitioners, nurses, doctors, OT, PT, specialists, etc. This is just an example of like what a calendar like parents would receive of what we would be doing for those 5 days. So typically arrival day is usually a shorter, smaller day because kids start arriving around like 1 p.m. We do like check-in. They have to like check in with our medical professionals and things like that. And then day 2, 3, and 4 are like packed with fun and activities. And then day 5 is departure day. And then here are some photos of just some of the folks that help out at camp. So we have some on-site full-time staff up there. We have volunteers who just love the cause and love what we do, and they donate sometimes their time for the whole entire summer, and they come to every single session. We get a lot of like students who are looking to go into like OT, PT, or some sort of field, medical field or child life, things like that. We have our mesh specialist who like if we have any kids that need any like emotional, mental health support, she's there to support them while they're there. But there's a lot of us up there all having fun, but making sure everyone's safe and having a good time. And if you are interested in getting like more information, more flyers and things like that, you're more than welcome to email our director, Julia Bossi, or you can go on our website, thepaintedturtle.org. But Julia is also happy to answer any questions that you all may have or provide you with any flyers or anything like that if you are looking to pass things out anywhere you all are. If you meet families that qualify, she would be your go-to gal. And then we're just gonna share a video of one of our camper stories. Okay, perfect. Thank you for doing that.
My name is Peyton Marquez. I have Duchenne muscular dystrophy, which it basically makes my muscles very weak.
For Peyton's muscles, once the fibers tear, they never repair themselves. Over time, you become weaker and weaker to the point of paralysis. You know, your heart is a muscle too, and eventually your heart will fail.
We are scared, but you can't have fear. If you have fear, then it makes everything harder to do.
Do we just keep them in a bubble, never let them do anything, never let them experience life? Or do we allow them to go out there, take some risks, take some challenges, and enjoy life?
Today I'm going to Painted Turtle.
Starting with the parents, dropping them off, counselors out there in silly costumes, big wide smiles, giving the kids the message. We're here to have fun. This place, everybody can win.
The Painted Turtle, they have the
suspense. It's with all kinds of disabilities, and
processes in place to make sure your children are safe.
All right, so you're excited?
Yeah, very.
Yeah. Do you have any like routines for taking the meds that I need to know about?
They have a state-of-the-art hospital there that doesn't look like a hospital.
Most of our campers, they have spent a good portion of their lives in the hospital.
Some of these families have gone through the gross amount that the insurance would cover.
The one building that you won't find here at camp, building department. Everybody comes free of charge to the pain attorney.
You know what we do guys upstairs? What's up? We share.
But I mean, in the big sense, like what did it mean to you? Was this? Did you see this as a last chance? Did you see this as a way to help other people?
A way to help other people, the disease, to help other people with the disease get better.
And why?
Because, you know, you can't just have a way of life where you just sit in a room, do nothing, watch TV all day. You need to do things outside and be a normal person.
Alright, you ready to fly? Yeah. Alright, team, let's go, baby, let's go.
You know, I always say about Peyton, his heart of gold, a smile that lights up a room, and once you meet him, you'll never forget him.
Yeah!
Something like the Peyton Turtle allows me to be a kid. It allows him to feel normal, to go out and have an experience that normal kids have. We are scared, but we can't have fear. If you have fear, then it makes everything harder.
Thank you.
I will be reading a few pages from my book. I'll be reading 7 pages. Okay, so it starts off by, "Hi, my name is Hunter. I have Duchenne muscular dystrophy. DMD for short. What is DMD? Well, I'll explain in this book. I'll also show you all the amazing things I have done. I'm smiling because I have been able to do a whole lot. I also have a big family and lots of friends." Then my story begins on a crisp Sunday, October 30th, 2011, with my arrival at Glendale Hospital at 16 months old. I joined my new family where my brother Evan was living. I was welcomed into the same loving family with my older brother Evan, marking the beginning of my journey. "I've been waiting for you. You're finally here," my mom says. "Welcome, Hunter. So glad to meet you. I'm your mommy." Wasn't I a cute baby? My mom said when I arrived it was a special day. She said everyone was so happy to see me. I don't remember, of course, but luckily my mom has lots of pictures so we can share some of our wonderful memories. We are one big, awesome family, and together we can overcome any obstacle. Then I remember when I was little, I enjoyed playing and running in the yard. Choo, 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 as I said. When I arrived to meet my mom, I was given so much love. I knew this is where I belonged. I had toys to play with and space to run and play ball with. My big brother Evan taught me how to play soccer. Come play soccer with me and my big brother Evan. My brother likes to skateboard, and my mom is great at skating. Using my wheelchair, I can go fast, and they both have to keep up with me. This is a perfect day for fun in the park, my mom says. My days were spent playing and running in the yard with my family. I thought it would be like that forever until my mom explained to me that I would have to start going to school. She also said even my brothers and sisters would go to their own school. That made me sad. Summer will be over soon and it'll be time for you and all the children to go to school, my mom says. Do I have to go? I want to stay here with you. After Hunter gets his recommended shots, have his doctor sign this form. The receptionist says, "Okay, great. I'll bring it back on the first day of school. So nice to meet you. See you soon." My mom went to our local school to meet with the principal and get permission for me to go there. My mom had to fill out paperwork and give them our information. She even met with the new principal of the school. My mom told me later that the principal said she would be very happy for me to attend the school and she looked forward to meeting me. Soon after, my mom did everything to prepare me for school. We went to the store. She bought paper, pencil, scissors, and a lunchbox and a really cool backpack. You're such a big boy, Hunter, and so brave. I know you can do this. Dr. Smith came. Wait. What? Mom, I'm confused. Do I read this first or this first?
Okay, you can stop right there.
But I want to read number 7.
Where's number 7?
This is number 7.
Read this first. Read this first, then read that.
Okay. Dr. Smith, can you take a look at this? I think we should do some additional tests. I'm not sure of what this is. I didn't like it when I had to get a shot in my arm. I remember feeling really scared. My mom had to hold me tight so I wouldn't wiggle or run away. The doctor was really nice. She smiled and told me to close my eyes if I wanted to, but I wanted to see what she was doing. I always came to the hospital as long as I can remember. I liked to see the nurses and doctors, plus they would give me candy and stickers. That's it. I decided to read a few pages of my book.
Okay, hello everyone. My name is Nicole, but nobody knows me as Nicole. They know me as Turbo's mom.
And I'm Turbo.
This is Turbo. Thank you all for being here, and thank you, Karen, for inviting us. I'm going to tell you a little bit about our family, and especially about my son, Josh, or as most people call him, Turbo. Turbo is almost 18 years old. He uses a power chair, and he uses it to lead the way, blazing through life with more attitude, more heart, more horsepower than just about anybody I know. If you've met Turbo, you know that he's not the type to let anything slow him down. Yes, he's diagnosed with Duchenne muscular dystrophy, but he's not defined by it. This past year alone, Turbo lived more in 12 months than some people have lived in their whole entire life. He rode a sidecar during the Sturgis Motorcycle Rally in South Dakota, cruising down the open road with his arms straight up and a smile from ear to ear. In Orlando, Florida, at the Cure Duchenne conference that we did, he swam with dolphins and sharks, which was pretty cool. In Kansas City, we visited the home of our favorite football team, Go Chiefs. And he rolled right onto the field of Arrowhead.
That's brave saying that in LA.
I know. Don't come for me, okay, people? Our latest trip was to New York, where he got to visit the memorial of the Twin Towers. And that's been on his bucket list for years. Paying respect there is very important to him. But here's the thing, none of this would be possible without the people who lift us up and support, and we call them our tribe. We have an incredible community around us, organizations like Hunter's Heart Foundation and Cure Duchenne, which we love with our whole entire heart. That's our community. We love connecting with other families that are going through the same stuff we're going through. I met Karen and Seema at the Cure Duchenne conference in 2023 in San Diego, and from that day forward we've been very much connected, so I'm incredibly thankful for that. Our biker family, the Mile Monsters, they're not putting the slideshow up, but later you'll see pictures of him with bikers, and they're long distance riders who travel thousands of miles a day, spreading awareness and raising money to help boys like Turbo. They just got him a ceiling track in his room. They've gotten a van. They pretty much anything they need to live. That's what they raise money for. So they're not just our friends, they're our family, and they love my son like their own. So we're very grateful for them. They are not always good days when you're living with Duchenne. There's a lot of appointments, decisions, moments that bring tears. But we've made a choice as a family that we're not waiting for life to happen. We're just out there living it together.
Yep.
You're doing great, son. Turbo's chair doesn't limit him. It's his ride into every adventure in life. And whether we're just blazing through Disneyland looking for stormtroopers, which is one of his favorite things to do, out on a racetrack watching his favorite cars zoom past us, or at home while he's hosting his podcast called Turbo Time on Tuesdays. Yes, he's living his best life. I want to leave you with a message today. Life is too short to wait for the perfect moment. Live it now, say yes more often, find your joy, find your tribe, and hold on tight, because even with challenges, your life can be epic, just like Turbo's. So that's it. That's all I have. Thank you guys for having us. Thank you, Karen.
Very awkward. I gotta go down slowly. Turbo has some awesome stickers.
Oh, he's got a new one coming out. Yeah, we don't have enough for everybody. He does have some though. If you guys want one, he has stickers. So, thank you guys. You want to say anything, Turbo? No? Okay. All of a sudden. Oh, Trish. Sorry. Thank you.
All right. Thank you, Nicole. Thank you, Josh. Thank you, Hunter. I actually want to finish the book. How many of you have read the whole book, the entire book? I think I want a book.
Go to our website.
Okay, yes. So a couple of announcements before we bring our next group of panelists. Let's see here. September 20th, Hunter's Heart Foundation will host its second annual 5K. If you did not pick up a flyer, please do so. We would love to have you there. It is at Whittier Narrows Recreation Center, the park. And we just roll, we ride, we stroll, we run, we walk, we crawl, whatever. Yes, ride bikes. It's exciting. So we're inviting you. Save the date. September 20th is around the corner. We would love to have you there. Also, we want to thank our friends from Sarepta, Aaron and Nika, for being here. As I was talking to them, they did mention that there is a scholarship available. It's called Route 79 Scholarship Program. And it's for those students that are in college. They could get up to $5,000 of scholarship money for school, and also their siblings, up to 5 siblings, which is wonderful. The deadline's coming up May 30th. So, oh, very nice, thank you. And of course, we have Cure Duchenne's conference coming up next month as well in San Antonio, Texas. Yeah! This is a national conference. Last year was in Orlando, Florida. How many of you attended? We did. That was so much fun. A lot of our children and families just love the camaraderie, the family, and we also get educated. We learn so much from all the latest research that's happening. And then too, you received a survey. If you could please fill it out before we go home. We are mindful of everybody's time, and first and foremost want to thank you all for taking your Saturday to be here today. So let's continue on with the presenters. We have three wonderful ladies coming up, and we are going to start with the Senior Director of Cure Duchenne, Heather. Heather will join us up here. And then after Heather, we will have Dr. Heather, two Heathers, Heather Square, from the palliative care at CHLA will be joining us. And Karen, our Executive Director of Hunter's Heart Foundation, will give us our wrap-up speech. So Heather, number one, it's all yours.
Oh, yeah, thank you.
Here you go.
Hi, everybody. I know we're at the end, so I'm going to be really fast and I don't have any slides. So part of what I wanted to talk about today was just kind of give an overview for those that may not know about resources and support that's available. So maybe a little bit different than we saw from the Triumph Foundation. But as everyone in this family, everybody in this room that's been impacted by Duchenne knows, the information is changing quickly. There's lots of new clinical trials out there, lots of protocol, treatment changes, medication access changes, and we know there's a lot of questions. While Cure Duchenne doesn't provide medical care or medical support, we have a team of research scientists who really understand it from that perspective. So they're actually working with our early phase pharma and biotech partners. Part of what Cure Duchenne does is we some of the funds that we raise, we put into investing into that early research, so working with those companies who are, even before they're bringing these medications into human beings. And so we have a one-on-one program that we're always willing to, and it's not a one-time thing. We want to offer it to our families as often as they need it. If they're facing a question about a trial, maybe they were in a trial that stopped, something changes. We also have a certified PT course that we offer to physical therapists, and we also have a caregiver training program. And kind of like the doctor was talking about earlier, it's really important that you know the type of physical therapy that's appropriate for individuals with Duchenne, that your occupational therapists know that as well, because what we all think is intuitive or what we all think is the right thing to do is actually the wrong thing to do for Duchenne. We have events and we support events just like this one today. We support Karen and what she's doing for the community. And I think what I always try to make sure people understand, like, we're not, there shouldn't be competition in advocacy. We should all be advocating all the time. So, you know, I'm the one that's going to tell you the great things that PPMD is doing, or Jet Foundations, you know, Team Joseph, Little Hercules. I mean, everybody has a part. And as I always say, like, there's not too much advocacy that we can do out there. So that's really important. Talking about champions, and Karen, who's not in here, is a superb champion, as are other families here. And really what that means is that somebody just willing to reach out to a new family, kind of go first, as I like to say, connect, bring them into the fold, answer simple questions, kind of talk about, you know, your own experience, sharing, you know, how you approach, because not everybody finds out at 1 or 2 years of age. We know that the diagnosis is still late. But we have a lot of events. You'll see us on social media with many things. But really what I'm here, and we have our big family event coming up in Memorial Day weekend in Texas. And I think we've got a lot of attendees here, so that's exciting. We still have additional assistance available for families. So if you know somebody who is not coming yet because maybe there's a barrier to them being able to attend, we want to help with that. So let me know, email me, contact me. And that's really all I wanted to say today. We also are having a full Spanish track at Futures this year, which means that we'll have not only translation, but we'll actually have healthcare providers, PTs, OTs, where we'll be not an aside, it'll be in parallel to what we're doing, and that's really important to me. For our siblings as well, I just secured an amazing speaker. So I'm really looking forward to it. If there's any questions that anybody has, please don't hesitate to let me know. If you have ideas of things we can do better or ways we can support the community, just let me know. Anyway, short and sweet. Thanks. Want to hear palliative?
Yes, yes. And now Dr. Heather for palliative care.
Do you, I think, I have them on a USB if you need to.
The gentleman right there is the one in charge of IT. Let me see. Here, do you want to put this on?
Oh, sure. I think mine's some slides. I have them on a USB. Is that easier? Yeah. Duct tape together.
Still works.
It should be probably this one from me. Yeah.
First one? Gotcha. And
Great. All right.
So while they're doing that, oh, she's ready. Okay. While they're doing that, we also want to offer something to the parents. So I don't know if you've heard of sound therapy. It's very relaxing and very calming. So we have someone here that's going to do a 5-minute session at the end. If you stay, that'll be the last thing. We're going to do sound therapy, just so you can walk away with something for yourselves, okay? Thank you.
That's so lovely. Wonderful. Hi, everyone. I'm Heather Bemis. I am a pediatric psychologist by training, and I'm part of the palliative care team at Children's Hospital LA. Just want to start off and say, first of all, I'm so honored and humbled to be here. It's a really special community, and it's not at all lost on me that you all have a lot on your plates. A lot of competing priorities. I'm being told that I'm too quiet, which is usually the case. Can you hear me better now? Great. Yeah, I know you have a lot of other places you could be, and to choose to be here and educate yourselves and connect with each other is really just an extra testament to what a special place this is. You guys are amazing. I'm going to tell you a little bit about palliative care. Not many people have heard of palliative care. It's pretty normal to have some misconceptions about what palliative care might be, especially in the pediatric space. So just here to offer a little bit about who we are, what we do. Nope. Great, so little roadmap. We'll talk about what it is, who might need it, when it might be a good time to ask for it, who we all are, who you might see if you come see us, at least at CHLA. And then I'll talk a little bit also particularly about my role as a psychologist on the team. All right, so in a nutshell, palliative care helps with symptom management. So we know that kids living with all different kinds of complex chronic illnesses are living longer thanks to lots of new great treatments. That's amazing. And what our job as a palliative care team is to help focus on the quality of those longer lives, really help you live fuller through holistic care, and really be thinking about decision making and what matters to you. And that's going to look different for every single family. There really is no one size fits all. It's really about meeting families where they are, getting to know you, and then helping to be sort of an advocate for your voice and helping kind of coordinate care among the many teams that you see. So what we are is a team that is just an extra layer of support. We don't replace anyone. We just come on top. No other teams go away if we get involved. And we are here for any kid who has any kind of serious illness. And when we think about kind of symptom management, again, we're looking holistically at physical symptoms, but also psychological symptoms, spiritual, social concerns, anything that might be kind of coming up, along with the many complexities that we know come along with managing a chronic illness. That can occur at any stage of the kind of illness journey, whether kind of right at diagnosis, at a time that maybe something changes, or there's kind of a new treatment option that you're weighing out, or really sort of any kind of time that it's helpful to have a kind of sounding board to make decisions with from an interdisciplinary perspective. And again, another kind of big thing that we do, especially in the outpatient setting, is we know you're seeing a lot of different teams, and it is understandably hard sometimes for teams in the outpatient setting to communicate really smoothly with each other. And we're sort of a team that can kind of be there to help kind of hold the thread, talk to the cardiology team, talk to the neurology team, make sure everybody is just on the same page and sort of aligned with what you have told us is within your goals, makes a good life for your child and your family, and really sort of kind of be there with a bullhorn for that. So I'm going to address an elephant in the room, or I'm going to let this family, this wonderful mother named April, address an elephant in the room a little bit about some misconceptions about palliative care. Hopefully this will work. Let's see.
I definitely thought they were the Grim Reaper. I really didn't want to be associated with them. But every time we were in the hospital, they would come by. And they became friends who happened to work in palliative care instead of these palliative care haunts that kept showing up. So I was able to ask them things as an insider who just happened to be one of my friends. And getting to see them before I needed them was really immenseful for me. Because even though I didn't have an understanding what palliative care was, I was happy to see someone on the show, a team, who would always be there for us. The phone trees are horrible. Getting in touch with specialists are horrible. And just having a card and knowing someone actually answered the phone, and that they were never disappointed to see us. It wasn't like, you guys are here again. They're just like, oh, hey, Jackson, how's it going? You good? And I don't even know if they had to do a lot of things for me, but I knew that they were there. And I think for the clinical team, knowing that we were talking to palliative care and that we were walking through those steps made them feel better. That it was maybe one less thing that they would need to address, or they knew exactly who to direct our other questions to, because we were already connected. It helped. And then I'll even say this. In situations where you build more familiarity, and that doesn't usually happen in hospital stays, because even if they're extended, they're not back to back, right? If we can help it. You're not seeing the same staff, and even the physicians that are monitoring the case or managing it, they're not client-facing all the time. So I can go back to, not just writing on Dr. Johnson and her colleague Maura, they were the people that I saw more often. And then there was, I kind of exhale. I wasn't on, on show. I wasn't having, I just feel like, yes, I'm tired. Yeah. No, I was like, no, I broke down earlier. I'm okay. And that would be okay to say that. And it was more the familiarity and the fact that they kept showing up that we could build to that comfort. Now, any other provider that we're in a position to see, no matter what their demographic makeup, we could have potentially built that as well. The hospital system is just not designed for that. So the way that palliative care helps serve us is I know when they came in the room, I didn't have to be on. And so that was a break for me too. And it was like they were visiting me as just me and not me as Jackson's primary caregiver and the point of contact. It was with the familiarity.
Okay. All right, so you might have noticed a couple things in that video. A lot of people associate palliative care with end-of-life care. That is part of what we do, but in pediatrics, it is actually much more common for us to get involved really early, and it's really actually much more helpful if we can get involved really early, as April was sharing. If we can get to know you, who you are, what quality of life looks like to you, what makes you sing, what are your family's values, then if there does come a point when a big decision comes up or a big symptom management need comes up, then we know how to help that much better because we know what things look like when they're good. And so there's a lot of evidence that early involvement is really helpful, and in pediatrics, you can get that. Here's just a kind of like really quick sample with some additional parent reflections, sort of from across different points of an illness journey. So again, from the symptom management standpoint, one parent has shared with us, before my son got sicker, I met with the palliative care team in their outpatient clinic. We made a care and pain management plan so that he could live a better, more comfortable life, and then that came in handy when it was more needed. Sometimes we see kids who are kind of in and out of the hospital, and similar to April, we've heard from parents about how we could talk about things while we're in the hospital, how to keep people comfortable, how to support families, the entire family. So sort of like April was saying too, it might feel it might feel unexpected at first to come see a team where when you come to your child's doctor appointments, they really want to know about how you're doing and how all the siblings are doing. But that is really what we want to hear and what we're here for. We're really here to kind of focus on that whole family care. Again and again, providing that continuity. There to help my child be as comfortable as she could. Talked to me, gave me support when my child was uncomfortable, because we know that feels really hard for the whole family when that happens, and there to connect for other community resources. When we see families where a child does pass away, then, like I said, we are also there to help with that if that does come up. We then are there to check in. We can connect to bereavement resources, anything that might be helpful, and also just making sure that kids and families stay comfortable throughout their entire illness journey. And then again, much more often, we also are there when kids are ready to transition to adult care and they're doing great. And we help sort of hand off things to an adult care team. And again, making sure that some of that continuity and that voice and that sort of like long-term preferences is there and is heard. Again, just as far as sort of like putting the map together about sort of like what palliative care is in the pediatric space, another common misconception is palliative care hospice care. It is not. So hospice care really is sort of that sort of like end-of-life service. I will say that in the pediatric space, for those who do come to need hospice care, anyone under 21, based on the Affordable Care Act, can get what's called concurrent care. They can get hospice care at the same time as all disease-directed treatment, going to the ER, to hospital visits, all of this time, and still staying enrolled in hospice care. That is actually something that's available in peds. That being said, also palliative care is much more, again, that sort of symptom management across the trajectory of illness, there for decision making, all other kinds of support, and referrals to those community resources if and when they're needed. We do also pain management. There's sort of like a Venn diagram there as well too. There is, at least at At Children's LA, a separate pain management team. They are kind of our sister team. We work very closely with them. But if there's sort of like just a short term, like acute pain management need, like post-surgery or something like that, you might be more likely to see the pain team. Whereas if there's sort of chronic pain management that's going on alongside all of these other sort of complex chronic illness needs, then the palliative team is there to sort of hold that with you alongside all these other concerns. I know we're getting late in the day. I think I'm starting to repeat myself a little bit here, so I'll go through this just really quickly. But again, sort of the kind of like main takeaways of things that we do. Symptom management. So for example, things like pain or GI symptoms, helping with some sort of like out of the box thinking or along sort of like chronic symptom problems. We know that that includes also emotional symptoms. That's where myself and our social workers also come in, and that applies to your child with Duchenne's, your care, sibling care, whether support for you or helping with referrals. It will say that all of our visits with our team, we aim to really take a holistic approach on the ground. And so likely if you come see us, you will have a medical provider and a psychosocial provider in the room together. So an MD or an NP and a social worker and or myself sort of all together so that we can kind of make sure we're really kind of working together in the room at the same time. Again, communication and decision making, making sure everyone's on the same page, everyone has the sort of the same understanding of what's going on, what the goals are, what your preferences are, helping you identify that and helping communicate that across the care team. And referrals when need them to things like home-based palliative care. There are community agencies that do similar things to what we do, but can actually come to your home if that's easier. We work closely with a lot of community partners there, and other kinds of supports that we might identify that might be helpful to you. Yeah.
So, one of the big things in Duchenne now is a lot of our guys, which is great, are living longer and moving into adult care.
Yeah.
Are you part of like a transition team that helps as guys are moving from pediatric to adult care?
That's such a good question. At CHLA, we actually have a specific team that is there just for that. It's called the chat team, child something adult transition. And we work closely with that team, but we are separate. But if we're following a patient and they're transitioning to adult care, we always also make sure to have calls to coordinate with their primary doc at the new hospital. If they're going to be followed by adult palliative care as well, we hand off to that team, and so we kind of help make sure those coordinations are seamless. But then I'm not sure about like CHOC in UCLA, but at least at CHLA there also is a separate team of people who, when kids are readying themselves for that, will call you and will help sort of start preparing, because then you know that there's a lot of things to hand off and it's really scary. Like your providers know you so well. Yeah. Just a little picture of who we are. We have a sort of running unicorn theme on our team. At this point, it is like lost to history where that came from. But we are physicians, nurse practitioners, social workers, and a psychologist myself, who, like I said, all work together often and right in the same room together to provide this sort of biopsychosocial care. We also have an education and practice coordinator who helps sort of train other folks around our hospital in things like communication skills and things to kind of be on the lookout for in what we call primary palliative care that we want all of our providers to have. And then when you're scheduling, oh, he's not in this picture, but we have an amazing care coordination assistant named Kevin, who helps kind of coordinate appointments and does amazing care himself and is lovely. Just a kind of quick overview, lay of the land. We see kids, the takeaway here is we see kids from all across the hospital, all kinds of units, all kinds of diagnoses, and at all kinds of stages of their illness. We have a large component of outpatient care, and then we do also have an inpatient team. Of course, a lot of patients that we see in palliative care might be kind of in and out, and then we sort of follow sort of across those contexts. And again, it can be if your child is hospitalized, then having gotten to know you sort of in the outpatient setting at home and things can help us then sort of put forward that to the inpatient medical teams, so that they know you and can hopefully help you be more comfortable during your stay at CHLA if that happens. I talked a little bit about kind of sometimes to get involved. Again, shortly after diagnosis is a common time we get referred, but also anything that changes, if there are decisions coming up, or just, again, at any point that it feels helpful to have a team sort of where it's a sounding board to kind of be considering your holistic care, and just sort of kind of taking that bird's eye view and having the long-term vision with you. If your primary providers haven't brought it up or haven't referred it to you, that's actually pretty common. You know, that it's actually, like, a lot of doctors also have misconceptions about what palliative care is. So I will say, like, you can always ask. You can ask to see us. You can ask for a referral. We love that, and we love to get to know kids early, and just sort of be a sort of added layer in their care. And then really quickly, sort of about my specific role as a psychologist within the team. So if palliative care is an extra layer of support, or you like to call me an extra layer of support within that, I do join the interdisciplinary visits with our team, but also a kind of main role that I do is I take referrals from our team for psychotherapy. So if your child is having concerns related to kind of coping, how do I talk to my kid about their illness, about these treatments, decisions, how do we talk together as a family about it? You know, how do we navigate different changing concerns along with school and development alongside all these needs, like, you know, navigating transitions to middle school and high school aren't any easier when you're also navigating a complex chronic illness. And so there to give that space for processing, for self-advocacy, and when showing up to their own medical appointments and anything that can hopefully make things feel a little bit smoother. When I get involved, I also really like to do a lot of school coordination, so support with IEPs, 504 plans, all that kind of thing. Again, just taking that kind of holistic view to support coping, emotion regulation, and family provider communication in this sort of really complex sphere that you're navigating.
Is there, and you don't have to do it, maybe you could send it to Karen afterwards, but this is a conversation, and we get that reaction every time we say those two words. A book or educational material or pamphlet or brochure that you all have that would help us, you know, chat about this further as a community?
About
palliative care in general.
Yeah, I'll give you a couple of resources, I think, on the next slide. I will also just say you don't, at CHLA, you have to get palliative care to get me specifically. I'm just for the palliative care team. But in general, you also don't have to have palliative care to have a psychologist or therapist involved in your care. You know, anytime it can be helpful to see a pediatric psychologist or one who is embedded in one of your subspecialties. Cardiology at CHLA has a great psychologist involved as well. We work closely together. And, you know, that is someone who's going to be more likely to be kind of coordinating really closely with specialty care teams and have sort of that specialty training. But I also just want to acknowledge there are really great mental health agencies throughout LA and community services, and what's most important is that it's someone that you feel comfortable with, that you can connect with, that's accessible to you, and that's giving you support and skills that feel helpful. And so whether at Children's, whether through our team, or whether you're interested in kind of connecting with someone in the community, you can also always talk to us about that, and we can also help provide referrals. Yes, left side. So some of my favorite resources, a lot of them are right here, can certainly attest that Painted Turtle rocks. Like most, I've referred so many families there who have come back raving about it. And but I want to highlight in particular for you, Courageous Parents Network, if you haven't heard about it. That is a wonderful organization and mostly a online resource bank that was founded by a parent of a child with serious illness. And it's sort of by and for caregivers of kids with serious illnesses. And that video that I showed earlier came from that. And there are all kinds of video resources about different illness types, about decision-making guides with clinical trials, things like that, ways to connect. And it also has some really good kind of info for sharing, info about what palliative care is, and info for sharing about what palliative care is to others. And so that is sort of my kind of go-to resource for if you want to kind of spread the word. But you're also always more than welcome to contact me and our team. That's our team email there. I have cards with me. That's all I got for today. And any other questions?
How early do you typically get involved at CHLI?
Me personally or our team? It really, really varies. Yeah. For Duchenne's? Again, pretty variable. I think any time that a family is sort of kind of saying I'm having some sort of symptom management concern, oftentimes, or a concern about, I just want to make sure I'm maximizing my child's psychosocial development at school. Things like it can be that kind of concern too. I think that's actually probably the most common reason when we'll get involved with the Duchenne's. We tend to get involved with our Duchenne's cases a little bit earlier. I think in part thanks to organizations like this one raising the awareness, and but it may need to be the case that it might not be top of mind for your provider always, but you can ask for it if it sounds like it might be helpful. Yeah.
Do you need a referral from a specialist?
You do need a referral. It can come from pretty much it can come from your primary care doc or your neurologist, your cardiologist. You do technically need one of these sort of primary teams to refer. But again, you can ask them for that referral too. Yeah.
Primary could be pediatrician outside of CHLI?
That's a good question. Probably, and then they'll probably get in touch with our team. But I can also give you our cards that you can make sure if there are any hiccups, you can also sort of come to us. Yeah. Great. I know it's getting late, so. Thanks. Oh, thank you.
Good job. Thank you.
Wasn't that nice? Thank you so much, Doctor. So now we're going to move into the area we're going to have our sound healing session. You can put it on me if you like. Thank you. My name is Rayshana, and I am Karen's daughter. I do many things to help my mother and to help Hunter. And one of the things that stood out to me the most when, as my mother goes through this life with Hunter, is that I seen the stress load increase, right? So the effect that it has on the families.
And I wanted to do something. I wanted to contribute in a certain way, right? So I help my mother do whatever she needs. Of course, I wear a lot of many hats, like she wears the major ones. But one thing that I do professionally is I'm a sound therapist. And so this is my way of giving back to the children, to the families, and all the stress that you guys go through, and just giving you different tools to help you stay present, to help you release any negative energy or just any stagnant energy that you could be feeling when it comes to this disease and just everyday life. So I believe his name was David, the physical therapist. He gave you guys a exercise which is called 4-7-8, and it is the breathing exercise of breathing in, exhalation, inhalation, exhalation, right? So we're gonna do the same thing here as I move through the healing session. We're going to be practicing on our breathing. We're going to be practicing on staying present, and we're just going to practice releasing. So you can give yourself permission to just release any heavy feelings that you're feeling, anything that you're going through today, and to help integrate all this information, right? This was a lot of information. Some things were heavier for certain people. Certain things were not so heavy. So integration, releasing, and moving forward, okay? So the first thing we're going to do, well, I like to kind of explain vibrations, right? Because everyone's like, oh, I don't know if it's woohoo, I don't know what it is, but everything is made of vibrations. Our smallest parts of us are atoms, electrons, neurons, protons. They're always moving. Everything is in constant motion. So when you think of vibrations and you're thinking about receiving vibrations, understand that you are already vibrating at your own original tune. Everybody has their own original tune, like you have your own fingerprints, okay? So we're gonna start with a deep inhalation through the nose, exhaling out of the mouth like you're blowing through a straw. Deep inhalation through the nose. Exhaling like you're blowing through a straw. Taking our consciousness to the center of our feet. Inhale. Blinking open the chakra. Exhale. Taking your consciousness to the center of your hands. Blinking open the chakra. Exhale. Taking your consciousness to the top of your head, allowing it to slide back like a sunroof. Exhale. Deep inhalation through the nose and out of the mouth. Taking your consciousness to the center of your feet. Deep inhalation, bringing it all the way up and out of the palms of your hands. Deep inhalation from the palms of the hands, out of the soles of the feet. Deep inhalation from the top of the head, out of the soles of the feet. Deep inhalation from the palms of the hands, out of the top of the head. Deep inhalation from the bottom of the feet, out of the top of the head. And continue to breathe. The breath is where life is. Expanding our chest and our breath capacity. That is the breath of life. Deep inhalation through the nose. Blowing like you're blowing through a straw out of your mouth. Releasing any negativity. Inhalation through the nose. Out of the mouth. Taking our consciousness to our heart center. Opening up like a window. Deep inhalation from the heart, out of the crown of the head. Deep inhalation from the heart, out of the palms of the hands. Deep inhalation from the heart, out of the soles of the feet. And from the soles of the feet, out of the heart. And from the palms of the hand, out of the heart. And from the top of the head, deep inhalation, exhaling out of the heart. And since you are in your heart center, take a good look out of the window. Notice what you see. Notice what you feel while you're in your heart center. Now look to the left of you and push all those boxes away. This is your heart center that you're looking in. Push those boxes back. And look to the right of you and push those boxes back. Look in the front of you, push those boxes back. And look behind you, push those boxes back. Look above you, push the ceiling as far as it can go, creating more and more space in your heart center. Deep inhalation through the nose. Blowing out like you're blowing through a straw. Take notice of the window again of your heart and look out of the window. Does it feel like you have created more space? And if you have not, push those boxes further back, creating more and more space. Repeating after me. My intention is to release any negativity in, out, and through me, sending it out into the universe, rendering it harmless, never to return again. Amen. So it is, and so it shall be. Deep inhalation. Exhale. Very good. Release it. Give yourself permission to release it, whatever it is. Just like that. It's gone. Now, if you're feeling too crowded with your auric field, there's an egg-like structure all around you. And once you can see that egg-like structure around you, you're going to push it out 3 feet to the left of you, 3 feet to the right of you, 3 feet in front of you, 3 feet behind you, 3 feet above you, and 3 feet below you. And if you're feeling too expanded, too open, bring your auric field 3 feet to the left of you, 3 feet to the right of you, 3 feet in front of you, and 3 feet behind you, 3 feet above you, and 3 feet below you. Deep inhalation through the nose. Exhale through the nose. And continue to breathe through and out of your nose. Very good. Taking your consciousness to the back of your heart. And we're going to slide that back of the heart open. Taking a deep inhalation through the nose and out of the nose. And whatever is happening, allow it to happen. And as we come to the close, we're going to be closing our energy centers now. So now we're going to take the deepest inhalation we've taken today through the crown of our head, down to the soles of our feet,
back from the soles of our feet, out of the crown of our head, allowing it to well up like a spring, sprouting out all of the energy, the colors, knitting its way through your auric field, down back to the bottom of your feet. And we're closing the energy centers at the soles of the feet. Inhale. Taking your consciousness to the palms of your hand, inhale and close those centers. Taking your consciousness to the front of your heart, close the window. And to the top of your head, sliding it closed, allowing all those energies and colors to manifest inside. Very good. And that is all for your sound therapy session today. Thank you so much for allowing me to come before you. Thank you. Thank you.
Well, we come to the close, and I just want to say a big thank you to everyone, to Kaiser, who allowed us to host it here. Thank you. Ryan is not in the room, but I want to thank Ryan and his boss, Mitch, and all the staff that helped us set up the equipment. I want to thank our videographer, Damon, who has been with us 2 years now. All the volunteers that has helped, LA South Chamber of Commerce, thank you so much. Seema and Nicole, who are my sisters, you know, through this DMD journey, I really appreciate you so very much. To Children's Hospital team and all of the medical team that came, Kaiser's medical team, I'm grateful. To Cure Duchenne, Heather, you know how I feel about you guys already. Okay? Yep. Sarepta, my new partners in crime. We're gonna do this, right? And my goal was to, no crime, but you know, I meant that in the best way, okay? We're gonna break the laws of DMD, right? Okay, let's break those laws. Yeah, we break barriers. Yeah, thank you. But I'm just really grateful. I know this was a long day, and my prayer is that you receive something to walk away, to tell somebody else. We want something for the families, for the children, for the siblings, for the parents. Sometimes I just have to slow down, and I thank God for my daughter to say, Mom, stop. And so if you don't have anybody, get somebody, because this is a journey that never ends. And I tell people all the time, your life is not like mine, so don't compare it. But just join me on this journey. Thank you for your time. Have a wonderful, wonderful Easter. And if you have any of your surveys, can you please give them to Vernell? Thank you, Vernell, for your help. And that's it for today. And thank you for Ryan, and you were out the room, but thank you, Kaiser, again. Let's give Ryan a... Ryan literally crawls from one end of the city to the other. I said, where are you? He says, I'm on my way to Pomona. I'm on my way back to Downey. I'm on my way. So thank you, Ryan, for helping us through this process. I hope this is the first of many journeys together. Thank you so very much. We have young ladies out there that are from Be Nerdy, one of our partners. And they are amazing young ladies who help serve. So when you pass them, please tell them thank you. We're trying to give them tools for their future and you know, something to do, something positive to do and give back to the community. So thank you, and that is all I have. Thank you so very much. Yes, take some food. It's fruit, it's cookies, it's everything.